Welcome everyone, members, presenters and observers to this meeting of the Health and Adult Social Care Select Committee. A particular welcome to all the NHS personnel attending, given the stresses and strains brought about by the pandemic. The meeting is being held remotely and members are in attendance via video conferencing. The meeting is being live streamed and will also be available for repeated viewing. During the meeting, if a member wishes to speak, they will indicate by using the raise hand signal from the Teams menu, and I will call them to speak in turn. So I'm going to start now by reading the names of members of the committee so they can confirm their attendance for the public record. So I'm Councillor Roger Huxtep, I'm Chairman of the HASC. The next person on the list is my Vice Chairman, Councillor David Keast. David? We need to hear you, David.
Sorry, I've just switched it off. Good morning, Roger. I'm in attendance.
Very good. Councillor Martin Boyles.
Here.
Councillor Anne Briggs.
Good morning, everyone. Present, Chairman.
Councillor Adam Carew. Councillor Fran Carpenter.
Present, Chairman.
Councillor Tonya Craig.
Good morning, Chair.
Councillor Rod Cooper.
Yes, good morning, Chair.
Councillor Alan Dowden.
Present, Chairman.
Councillor Jane Frankham.
Oops, present.
Councillor David Harrison.
Good morning, all.
Councillor Pal Hare.
Good morning, Chair. Present.
Councillor Neville Penman. Councillor Mike Thornton.
Yes, good morning, everybody.
Councillor Ridgeon Vaughan.
Morning, Chairman.
Councillor Michael White. Councillor Diane Andrews.
Present, Chairman. Good morning.
Right, good morning everyone. Now we've got some extra names today because we're being joined by Councillor Julie Butler, who's a co-opted member from East Hampshire District, and she's replacing Councillor Trevor Cartwright. Councillor Julie Butler.
Good morning, everybody. I'm in attendance.
Good morning. Councillor Jonathan Canty. He is a co-opted member for Rushmore Borough Council, and he's replacing the late Councillor Alison Finlay. Jonathan. Not there yet. And Councillor Cynthia Garden, co-opted member, Eastleigh Borough Council, to replace Councillor Rosemary Reynolds.
Good morning, Chair. Yes, I'm present. Thank you very much.
Right. Good morning to you all again. Now, for clarity during the meeting, if the outcome of an item is to note the update, I'll ask for the members to unmute and confirm verbally if they're able to agree that outcome. If there is any dissent or request for recommendations, members please use the raise hand button and I will call you to speak. For any recommendations to executive members, an electronic poll will be conducted that will display to committee members. Members, please indicate your vote by using the appropriate button and hitting submit. The Democratic Services Officer will confirm the outcome of the poll for the record. I'd like to remind members that the Constitution's standing orders will apply. Also, please keep your microphone muted unless you have been asked to speak. So now we can go to the formal part of the meeting, the opening of the agenda. The first item is apologies for absence. Marie, do we have any apologies for absence?
I've not been notified of any apologies, Chairman.
Right, thank you. Declarations of interest. All members who believe they have a disclosable pecuniary interest in any matter to be considered at the meeting must declare that interest. Furthermore, all members with a non-pecuniary personal interest in a matter being considered at the meeting should consider whether such an interest should be declared. Are there any declarations of interest? No. Right, moving to the minutes. To confirm the minutes of the 10th of November.
You have a raised hand, Roger, from Jonathan Kante.
Thank you, David. Jonathan, speak, please.
Thank you, Mr. Chair. And yeah, just to also confirm my attendance at the meeting this morning as well. I just wanted to declare that I work through a national charity called Versus Arthritis, and to the best of my knowledge, the charity has no contractual arrangements with Hampshire County Council or any of the bodies being scrutinised today, but there are some items that will include discussion of issues that the charity does seek to influence policy on a local and national level, and those relevant items, I believe, would be number 6, 7, 8, 11 and 12.
Thank you, Jonathan. But there are, do you consider that those items are in any way pecuniary?
Possibly 11 and 12.
Okay, we'll bear that in mind when we come to those items on the agenda. Thank you. Any other declarations of interest? Julie Butler.
Thank you, Chairman. It's only a personal interest, and I don't think it affects any of the decision making today, but I am the chairman of Friends of Ticehurst, which is a fundraising organisation at one of your county homes. I have no influence on any budgets or anything else, or any decisions that are made within my role as a chairman, so I would assume it was just a personal interest.
Thank you for that. Any other declarations of interest? No. Okay. Right. Item 3, minutes of the last meeting. To confirm those minutes, they were added to the ModGov website separately to the main agenda pack. So I hope you've all been able to see them. Are they agreed?
Agreed.
Agreed. No items of dissent. Good. So they are agreed, and there are no matters arising not covered by the current agenda. So item 4 is deputations. My understanding is there are no deputations. Is that confirmed, Marie?
That's correct. There's been no requests for this meeting.
Very good. Right, item 5, Chairman's announcements. The Joint Committee on Hampshire Together. Right, at our last meeting in November, we determined that the Hampshire Together proposals by Hampshire hospitals constituted a potential substantial change in services. At the County Council meeting on the 3rd of December, a joint scrutiny committee was established to scrutinise the proposal, including representation from Southampton City Council, who also consider the change substantial. The membership of the joint committee is as follows: Councillors Anne Briggs, Fran Carpenter, Rod Cooper, David Harrison, myself, David Keast, and Mike Thornton from Hampshire County Council. And we're also joined in that committee by Councillor Professor Barry Margetts from Southampton City Council. The first meeting of the Joint Committee was held on the 18th of December, and I was elected as chairman. We had a useful initial discussion of the Trust's plans for consultation, and we will be holding a further meeting in 2021, probably in February. And it's now anticipated that the public consultation will start in May after the local elections. But even that, of course, is not yet confirmed. Probably some of you saw reports over the weekend that there may be delays in the local elections. I've heard June, July, September and October muted. So we'll just have to wait and see how that works out. The next thing is I'd just like to go through the approximate timings for this agenda so that you've got an idea in your mind of where we're going. We should allow an hour or so for the COVID updates. As you know, the COVID items we address at the beginning of the meeting, so that's items 6, 7 and 8. So from about 11 o'clock, for about half an hour, we'll address item 9, which is the Beckton Centre and the out-of-area beds update, by which time we'll be ready for a screen break and a leg stretch of about 10 minutes. And then we'll go on to the NHS 111 performance. And following that, we'll declare a lunch break, depending on timing, for half an hour, and then cover the county's 2021-2022 budget items. That's items 11 and 12, and then finishing with the work programme, hoping to conclude around 1:30. If we finish earlier, that will be a bonus. So now we can go straight into the substantive part of the agenda. Item 6, which is the NHS Hampshire and Isle of Wight COVID-19 update. There are pages 5 to 14 in your packs. And we've also got, in addition, an update from Frimley. As a result of a request by Councillor Cooper for attendance from Frimley, we've invited Frimley to attend this meeting only because, as many of you will know, the Frimley footprint does impinge on Hampshire, so there are Hampshire residents taking advantage of the Frimley Health NHS Foundation Trust, and it's only right that they should also have an opportunity to tell us what is going on in their neck of the woods. So can we start the presentation? As I understand it, we've got Dr. Andrew Bishop and Jenny Irwin. Is that correct? Are they with us?
Yes, I'm here, Chairman.
Thank you. And what is...
I'm here too.
That's good. Okay, so over to you. I don't know which one of you wishes to start, but go ahead, please.
Thank you, Chairman. I think with Jenny's permission, and we have briefly talked about this. I think the two substantive items that you'll want to hear about is, first of all, the current state with regards to health services in the pandemic, and then also the vaccination programme. And Jenny, with your permission, is going to take the vaccination programme. I will outline for you and then take questions on the current state of health services at this stage in the pandemic. And you have a paper in your pack, which is a guide to where we are with this. You will also know from following national news that this is an incredibly volatile time in health, and already the paper in your pack is significantly out of date. And the update I give you now will probably not be true tomorrow. So the things are moving, as you know, very quickly. I think the second thing to say is that it's an unprecedented time for everyone to know quite a lot about what's going on in health. So I won't spend a great deal of time giving you figures and information, because the profile of this is so high that you will be following the national news and know, of course, that the health services are under extreme pressure with the COVID-19 pandemic, and particularly the new variant of that. And you will know, of course, that we're in a part of the world which this time round is having a significant escalation of the impact of COVID compared to other parts of the country. And we are adjacent to London. I think in terms of the southeast, we are part of the southeast, but we are not in the same situation, have not been yet in the same situation as some of our colleagues in Kent and Sussex. So it's a busy time here, but not as busy as if we were in London or as if we were in Kent. The first thing to say is that I think it is worth understanding that the effects of the pandemic on health services is variable, and it is variable by geography and it's variable by sector. And within Hampshire, Isle of Wight and our footprint, there isn't a uniform distribution of the pressure of COVID. And I think it is worth recognizing that there is a particular pressure, which is of relevance to us all, in Portsmouth. And the effects of the pandemic are disproportionately severe there, both in terms of the presentations with illness and its outcomes, and also the pressure on the services there. And the Isle of Wight is becoming quite a pressurized place. But in Hampshire, while we have a very significant presentation of the COVID, it's not as severe as it has been in Portsmouth. The second thing, I suppose we have our friends from Frimley coming, and of course, Frimley is also very pressurised compared to the rest of North and Mid Hampshire, and we'll be hearing from them later on, I think. I think it's also worth understanding that the pressure is variable according to what we would call sector. So there is great pressure on our primary care services, partly because they're so consumed with having to deliver vaccinations, but also because of the presentations with COVID. And therefore, while there are still general services in our general practices, they are increasingly constrained, and access to those for routine care is becoming increasingly constrained. And if the present rate of growth is anticipated, we may well get to the stage where we had a similar situation to the first lockdown, where primary care is almost exclusively devoted to managing critical care and the critical illness, and then the COVID-related illness. As you go through the system, then through community care, into hospital care, and into critical hospital care, there is a great deal of pressure, but still coped with in community care. The hospitals are under great pressure, and I will finish this by giving you a personal experience, because I've been the physician on call in the Basingstoke Hospital over the weekend. Just in terms of the understanding of the pressure in the hospitals, we have about 3,000 beds overall in our hospitals, and at the present about 1,000 of those have patients with COVID, and that number is going up every day. And you can imagine, therefore, that that's a very significant pressure, and is now disproportionately the biggest group of patients who are in our hospitals. More pressurized than that, there is our critical care services. When we started started last year, we had about 100 critical care beds in Hampshire Isle of Wight. We now have between 150 and 200 patients with COVID in our critical care facilities. And we're in the process of expanding those critical care services substantially, so that the vast majority of the real critical pressure is actually in the critical care. So that grade or gradation of pressure, I think, is worth understanding. So two brief further comments on that. The first of which is where we are formally with regards to response. And of course, we are in significant escalation of all health services with their orientation towards managing the pandemic. And to that end, we have now suspended once again almost all elective services other than what's called categories 1 and 2. So categories 1 and 2 is elective services that are life-saving procedures. This is cancer surgery and other major surgery. But the vast majority of other elective services, which have been sustained until now, are increasingly being stood down in hospitals as the pressure from COVID becomes intense. We've also had a substantial step up of our engagement with the independent sector, and once again the independent sector is now coming under the wing of the total pandemic response, and there are active discussions about the best use of our independent sector facilities, both to maintain critical services and actually to act as resilience for and capacity should there be further surges in need for inpatient care. We're learning how to do escalation, and so a significant amount of time that we spend is working out how to create more capacity, because the modelling suggests that we are still not at the peak of this. And I'll detail that in a moment. But I think the fourth point about our current escalation response is to identify a thing that we now call mutual aid, which is because of the variability of the activity and presentation of COVID across the county. There are now in all sectors and in all organisations very advanced ways of delivering mutual aid. So, for example, there are patients being transferred from between critical care units as one critical care unit becomes pressurised. There are patients who are in ambulances that are in one hospital. If the wait becomes too long, and that's often Portsmouth, they're diverted elsewhere. And we have, until recently, also been offering mutual aid to our colleagues in the Kent hospitals, and have taken a number of patients, between 10 and 20, by direct transfer from there, although that is becoming more difficult as our services become pressurised. So active mutual aid is part of our escalation programme now. The planning, because the modelling suggests that this will continue to get worse before it gets better, is nearly all about expansion of services again. And the two areas where we are still actively expanding services is in community services, in order to depressurise the hospital and allow people to be discharged from hospital, and the expansion of our inpatient community support, expansion of domiciliary community support. And again, the propositions that we might expand beds into other sectors, that's actively being worked through this week. And we have a continuing critical care escalation program in the hospitals, aiming to move towards between 300 and 400 critical care beds available in the not too distant future, in a way that, remembering that we started off with about 100 a year ago. Of course, the major constraint around all of that is not actually infrastructure. The major support problem around that is staffing. And the two problems with that are that the pressure disproportionately is in hospital and critical care. And of course, that requires special skills, which not everyone has, and therefore we're actively trying to redeploy people in hospitals towards critical care. But of course, there is the issue about the relevant skills. It's also true that health service staff has been significantly affected by the COVID pandemic for individuals, and there are significant numbers of individuals who are both affected by the problem and also affected by the need for isolation. And staffing is becoming the significant constraint around capacity, although I think you would want to know that one of the technical issues, in particular in our hospitals in Basingstoke and Winchester, for technical reasons which are not easily solved in the short term, the constraint in critical care has become actually our ability to deliver oxygen. There are lots of technical reasons around that, but that may well limit the expansion capacity in our hospitals, Basingstoke and Winchester, and emphasises the need for mutual aid and treating our capacity as a mutual asset rather than an individual one. I'd like to close, Chairman, just by giving you a personal reflection, because I spent the weekend as the physician on call in our hospital, particularly in Basingstoke, and the situation is as you will have seen on media. It is true that the majority of the acute clinical work now in the hospitals is devoted to the COVID patients with COVID in one way or another. We've seen what we saw before, which is that the other presentations to hospital seem to have reduced a little with the awareness, I think, of the population that there is pressure in hospitals. We have seen a reduction in the total number of attendances, although we have disproportionately those patients are now patients with COVID. I have to say that a weekend in our hospitals reminds us what an asset the staff are, and reminds us also how grueling this is. But I would pay tribute to the people who work there under these very, very difficult day-to-day pressures. And at the moment, I think our message would be that health service is under significant pressure, but in all sectors, we're not falling over, and we're still open, and we're still there to look after people as and when they need our services. And we would want to resume normal work with our elective services again as soon as we possibly can. There's much more I could tell you, but perhaps it's best if I just stop and open up for questions, and I'm happy to answer questions as I can.
Thank you, Dr. Bishop. The media news this morning was stark, and you presented evidence this morning that there is good reason for that. And we all applaud you and all your NHS colleagues in striving to do what you are doing. And it's good to hear that you're even in a position to offer mutual help to other hospitals, although obviously from what you're saying, that is going to diminish. Now, do you want to take questions now, or do we hear your colleague? Actually, I've got some hands up, so we'll take questions now, and then we'll go on to the vaccination presentation, if that is okay.
Of course, yes.
Jonathan Canty, did you put your hand up?
Yes, I did, but I think there were others that were in the queue before myself.
Yes, I'm with you now. Councillor Briggs.
Sorry, Chairman, did you say me? I couldn't really hear you.
I did say you, Councillor Briggs. Go ahead.
Thank you. Thank you, Dr. Bishop. Like everyone else, I'm exceedingly grateful, and I think you're all doing an amazing job in these difficult times. But my question to you, please, is how do you safeguard patients that I was nearly late logging on this morning because I had a lady ring me up. Her husband went into QA with a broken hip 5 weeks ago, and now he's dying of COVID. And her question to me was, how did that happen? And I would like to know, he was in a ward with 4 other people, and one of the people in the ward had COVID. How well are new patients screened when they come in?
This is a really crucial issue, isn't it, really? Because we think of hospitals as places of safety, but of course, they are also places where there's a lot of people with COVID, and therefore there is the risk of. The technical term for this is patients who acquire their COVID infection in hospital. And this is a very significant problem. The technical term there is nosocomial. And this has become increasingly an issue of the way hospitals operate to try and prevent this happening. So there are all sorts of things that people do. And just to outline those, everyone who comes through the hospital has immediate testing to see if they have COVID. There's regular testing. There's entire isolation of patients who are in who have any sort of risk of having COVID until such time that we know that they're negative. And the staff, of course, are regularly screened as well. And so the situation that you describe is fortunately relatively rare. However, it isn't possible to completely eliminate it, because as you'll understand, there are people whose initial tests can be negative, but it can turn out to be positive. So we do have evident instances in hospital where people do find themselves exposed to the COVID virus and to contract COVID as a result of that in hospitals. Infection control is now extremely active, and there are many things we're doing with that. But I think that the part of the reason for minimizing the number of people who come into hospital for anything other than COVID-related illness is exactly this, that we cannot eliminate the possibility that people are exposed to the virus, and therefore our responsibility is to try and minimize the number of people who come in. The situation you describe is not common, but it's tragic, and it is something that is perhaps the most difficult for us to deal with, which is people who come in for something else and then contract COVID and become unwell. So sympathy is there, and it's an active problem that we're actively managing but can't entirely eliminate.
Thank you. Chairman, may I just ask one more question?
Yes, before you do that, I just want to say to Dr. Bishop that clearly he is in an operational setting at the moment. I can see personnel darting around behind him. He must not, Dr. Bishop, you mustn't feel inhibited about responding to what's going on in your hospital rather than attending to the HASC. So
yeah, no, thank you very much.
Away, do that, and we can always email you questions subsequently. Councillor Briggs.
Thank you, Chairman. This lady also asked me, it's a problem people are facing. Should he is dying, she's been allowed in once to see him. Should she be allowed in again? And I did tell her I was on this morning and I would ask, so I'm sorry for taking advantage.
Yes, the answer is that is a decision that's being taken by the local teams and the local staff. And so she will be able to be in contact with the people who are caring for him, and they will have a local view of trying to balance the need for her to have access to him with the need to keep her and other people safe. As a blanket policy, there is no ban to that. However, there is an extreme need to keep people away who constitute any sort of risk, and therefore she needs to talk to them locally about that. But they will make every effort, I'm sure, to accommodate her.
Thank you very much.
Thank you. Councillor Carpenter.
Thank you very much, Chairman. Yes, and also I'd like to say, of course, Dr. Bishop, thank you to everyone. My question is about the independent sector. I just wondered what sort of contract the NHS has with private providers and how that is put in place and what you expect them to provide. And also I was wondering, is it when they take on NHS patients, as I know they do, is it costly to the NHS more than usual, or are they? Is it a fair arrangement? Do you feel it's a fair arrangement in financial terms?
So in the first wave of the pandemic, you'll probably know that there was a national program which contracted the majority of the independent sector under national terms and conditions and under national management. And the terms of that was that it was essentially the same terms and conditions of the health service. So it wasn't that there wasn't, it didn't appear to be a profiteering approach to that. In fact, it was the opposite. That contractual arrangement came to an end at the end of last year. We are now under new contractual arrangements. And the difficulty about that is that right at the beginning of the year, those seem to be less devoted to health service resilience. But as the pandemic over the last fortnight has racked up, that's changed again. And we now have a situation where large parts of the independent sector are essentially commandeered to health service. And we're in what's called independent sector surge at the moment, which is that we are now actively planning to use independent sector not only for the maintenance of elective work, but actually to use it as capacity should we need to for urgent care in patients who are actually suffering with COVID. And the contractual arrangements, I think, are fine with that. And we're moving at speed to really use the independent sector simply as part of the available health resources in the county.
Thank you very much. Thank you.
Thank you, Dr. Bishop. Next question comes from Councillor David Keast. David, we need to hear you.
Sorry, I beg your pardon. Good morning, Andrew. My question is regarding, you touched on Portsmouth figures being very high. And of course, people in Portsmouth use Queen Alexandra Hospital. Those figures also spread out into the area surrounding Portsmouth, particularly, for example, my own patch of Havant. Are those, and we all use QA as well, are those figures from southeast Hants, are they included in the Hampshire figures, or are they included in the Portsmouth one, as it's a Portsmouth hospital they're going to?
Are the Havant figures part of what's reported? Is the question, are the Havant reported as Hampshire or Portsmouth?
Well, anybody that actually is surrounding Portsmouth that uses QA in southeast Hants, are they included in Hampshire or Portsmouth figures?
Okay, most of the reporting we do in health is organisation based. So we see what's happening in terms of activity in the hospitals, and therefore, and that's what we use. So people from having to go into Portsmouth Hospital, we would see as active in Portsmouth Hospital.
Thank you.
Thank you, Dr. Bishop. Next question comes from Councillor Jonathan Canty.
Thank you, Chair, and thank you, Andrew, for giving us your presentation. I just wanted to follow on the question that was raised by Councillor Carpenter about the use of the independent sector. Just wanted to ask again, sort of how much additional capacity the independent sector is adding to the trust at this point in time, and how much more you might need from the independent sector to meet current levels of demand for care.
Okay, the independent sector in totality, in Hampshire, probably is between 5 to 10% of the total capacity. During the first wave, the majority of that came under the use of the health service, and the more recent plans were to use approximately 50%. As we're moving, as we speak, that's changing enormously. And I think if the projections about this week and next week are right, then I think essentially we're likely to use it will just become part of our total capacity. I think it's worth saying that that independent sector is not the same as hospitals, and therefore has very, very limited critical care capacity. And it's much more, so therefore you can't just use it as another bit of hospital. The two things to say about it are, first, we are beginning to plan for the use of the independent sector as additional ordinary beds. But there is also a crucial role for it, which is the protection of cancer surgery, because cancer surgery is very difficult to maintain in any of our hospitals now, but is absolutely life-saving. And therefore, we have what's called the Hampshire Isle of Wight Cancer Hub, which operates out of the Spire Hospital in Southampton, and we're able to protect that there as a place for surgery that can't be deferred, but is a COVID clean site. So it's a mix of the way we use it in both of those ways.
Okay, thank you very much.
Thank you, Dr. Bishop. That was very reassuring, I'm sure, for cancer patients. Just one final question, if I may. You mentioned oxygen shortages. Now, that is obviously critical. Is that being properly addressed with some force by some outside agency?
Yeah, so just to be clear about shortages, we have not yet found the situation, but this is almost exclusively in Winchester and Basingstoke hospitals. We've not yet arrived at a situation where that becomes an issue which is unmanageable. But what we're aware of is that the oxygen use in those hospitals is getting towards its capacity, and therefore, in theory, could become a constraint were we to want to expand further. So there's no alarm about lack of oxygen in those hospitals at the moment, but there is a concern about trying to expand further. We have been addressing this since last year through the Local Resilience Forum, and the Local Resilience Forum and the national team are well aware of this. There are only limited things that you can do about this because there's a significant amount of infrastructure problem that you can't resolve just simply by bringing in oxygen on the back of a lorry, and some of it is about the pipes and the flow rather than the actual availability of oxygen in the hospital. There is a difficulty with oxygen supply nationally, and therefore that does become some constraint as time goes by, and we're in the queue for that. So what I would say is the message would be it is okay at the moment in those hospitals. There isn't a resilience issue as we speak. There is a significant constraint to expansion. There is no lack of visibility about that locally, regionally, or nationally. There are a limited number of things that can feasibly or technically be done to support that in the short term, but we are actively engaged in all of those.
Thank you, Dr. Bishop. That is reassuring. Essentially, the media this morning wasn't clear in my mind. So it's not the gas as far as you're concerned, although it will become critical potentially. It's the apparatus that supports it that is the difficulty.
It is both of those things, yes.
Yeah. Councillor Crewe, did you want to ask a question? Your hand was up.
Yes, Chairman, I do. Proceed.
Please.
Can you hear me?
Yes, go ahead.
Right. You mentioned this morning regarding the ability that we need to scale up and have more critical care beds. To what extent are our community hospitals being utilised? I speak specifically about East Hampshire because my current understanding from a colleague in Petersfield is that although the Petersfield Hospital is open, the Alton one isn't. And of course, we've got Chase Hospital in Borden more or less standing empty, all of which could be used, providing you have the staff, for beds.
Thank you. Yes. So the use of community capacity is important because many people who are in hospital at the moment, in theory, under some circumstances, could find their care in community closer to home and in community facilities, and therefore free up general beds in the hospital. So it's a very live issue, and there's a cell of the Local Resilience Forum very specifically devoted to maximising the use of this and coordinating the use of this. I think as a generality, I would say that there has been over the last 2 months a concern that there is capacity in those hospitals, that for some reason there are technical and procedural reasons why we haven't been able to transfer people out. I think we're at the tail end of that problem now. I think the actual processes for maximising the use of that capacity are now much more streamlined and in hand. I think the challenge is how we escalate beyond what we have at the moment, should we need that. There are bits of local capacity that you refer to, And if there are specific questions about the local ones, I know Jenny's on the line and she probably knows the detail of any particular area where we are with regard to any particular facility. But the general principle is that the community providers have stood up significant amount of extra capacity. We are addressing the issues around trying to make sure we use it maximally. And wherever we're aware that there is an issue, we make sure we streamline those processes. Last thing to say about that, Councillor, is that there is now this concept of mutual aid in community facilities as well, because staffing is always critical for these places, and therefore we're making it very easy for staff to move from one facility to another, one environment for another, in order to support that, to make sure we make maximum use of a staffed available capacity. Jenny, I don't know if there was anything else you wanted to just comment on that.
No, I think that's fine, Andrew, and the same is true for primary care as a sort of a broader component of the community capacity as well.
Thank you both. Dr. Bishop, I think probably it is now time to hear what Jenny Owen has to say. Do you wish to stay on for that, or do you wish to disappear and carry on with the battle?
I will listen to Jenny, but I might dip out depending on how the battle's going, if that's okay.
Exactly.
Thank you for your time.
Thank you for your time and the valuable information you've given us this morning. Jenny, would you like to go ahead with your presentation, please?
Yes, thank you. I will do, Councillor. Firstly, to say my sincere apologies for not providing you with a detailed set of slides to go through. It had been my ambition to do so, but as Andrew said, the information we have is moving so fast, it's almost impossible to put pen to paper before what you say becomes inaccurate. So at this moment in time, we're finding the most effective way to brief people is to do so verbally. And certainly if people have questions that I'm unable to answer at this moment in time, I'm really happy to take those away and to provide you with fuller answers in the fullness of time. But essentially, I did just want to start by focusing in on what Professor Chris Whitty said this morning. I don't know who caught his comments in the media, but essentially the vaccination programme is very focused on saving lives and preventing hospital admissions, which dovetails in neatly behind what Andrew has said about the current pressures for all patients accessing services and on the NHS most generally. So people will be aware that the vaccination programme is rolling out across the nation with, at the moment, the two agreed vaccines. They are the Pfizer vaccine, which is the one you will have heard about, which has to be stored at -80 and essentially needs large swathes of people to be brought to the vaccine, as opposed to the vaccine being then distributed more widely. So it's quite a static product that needs lots of people to come to it. That one was approved first before the Oxford AstraZeneca vaccine, which is the one which you'll hear is able to be stored at different temperatures and can be broken down into smaller batches and moved around, and is far more suitable for things like care homes, people who live in their own houses who are housebound, etc. So the NHS took the approach to stand up the vaccination programme as quickly as possible with all the resources that we could provide to it, with whichever vaccine supply we had, in order to vaccinate as many people as possible as soon as possible, which is absolutely aimed at saving lives and preventing hospital admissions. JCVI, which is the Joint Committee for Vaccinations and Immunisations, is a national body. You'll probably be aware of it, but essentially its role is to set out the cohorts of patients and people who should receive the vaccine and in what order. At the moment, the instruction from the top of office is to proceed at pace with vaccinating cohorts 1 through to 4. People in those cohorts are people who live in care homes and the staff looking after them, NHS health and social care staff, and people over the age of 80. Those are the people, if we vaccinate first, will have the biggest impact on saving lives and preventing hospital admissions. So we're very clear that that is the process and the plan that we're following at the moment. One of the questions that I receive 3, 4, 5, 6 times a day from everywhere, from organisations and bodies to members of the public, is when is it my turn, which is absolutely crucial question for absolutely everybody, and I fully recognise that everybody wants to know the answer to that question. And I think given what we heard in a discussion with our senior leaders last night, there will be a ministerial announcement, I believe, over the next couple of days, which will be very much about sort of announcing the broader NHS-wide plan. At this moment in time, the kind of detailed numbers are very much embargoed through the NHS communications route, so I can't at this moment in time share any detailed data with you. But what I can say is that Hampshire and Isle of Wight is doing very well within the region in terms of the number of those cohorts and those people that we have got through in terms of our vaccination programme. In terms of what we've got and where it is in terms of vaccination components, the model has 3 sections to it. The first is our primary care networks, PCNs, and they have come together in groups of GP practices to provide at scale where it's most appropriate. So the primary care networks came together, remember, initially on the basis that they would be in receipt of the Pfizer vaccine, which then can't be transported out to lots of other people. So they did need to come together to provide scale so that they could draw components of populations and people into one place and vaccinate lots of people. So some of our primary care networks have come together in large groups, such as up in the north of the Hampshire patch, where they're operating out of the Apollo Hotel, and some of our primary care networks are working in smaller groups. But that has been absolutely done from a bottom-up process. So each of those PCNs told us what they thought was most appropriate. They know their populations, they know the people they're looking after, they know their GP practice lists, and they know what's most practical. So they've come to us and said, this is how we want to operate. We've stepped all those services up in accordance with that model. And across Hampshire and the Isle of Wight, there are 39 sites where the primary care networks are vaccinating from. I'll let my Frimley colleagues come in and talk about the North East Hampton Farnham patch, because that number is not included in that. So I'm talking very much about the Hampshire and Isle of Wight ICS bit, but I'm very conscious that from a completeness point of view, you'd like to hear about the Frimley components of that too. But in addition to that, we also have what are known as hospital hubs. The hospital hubs have been stood up essentially to focus on vaccinating ideally their own staff, and opportunistically the over 80s population as well, because clearly where people are already in hospital or coming into hospital for essential appointments, it's key to vaccinate those individuals as well. What we don't want to do is to draw significant swathes of members of the public onto hospital sites and put them and others at risk when they are able to remain in their local community. So there's definitely a delicate balance with those people in opportunistically making sure that we can vaccinate as many of those over 80s as possible, but not bringing people into hospital if they genuinely don't need to be there. So the hospital hubs have been working on that basis, that they've been doing people over the age of 80 and health and social care staff too. So they're now working very closely with Hampshire County Council. We have subject matter expertise sitting in our group, in our vaccinations board, and the operational teams are working together to really bring forward all of those health and social care staff, and to ensure that when we go through the nursing home community and care home community, that we are looking at homes that are, we're prioritising homes that have more than 50 residents in them because of the spread of ability of supply of vaccine into those environments, and we're working through all of our care homes at pace, being a high priority for us across that group. So the other component of our model, which hasn't yet commenced, is the vaccination centres. Vaccination centres, that the model is expected to operate at scale. So the idea being that those would be very large places where lots of people could be vaccinated on one day, up to as many as 3,000 people a day. In our discussions across Hampshire and the Isle of Wight, we felt very strongly that Hampshire and Isle of Wight having one place where that would happen would immediately be inappropriate for at least 2/3 of our population, because when you put something once in the middle of Hampshire, it's clearly not going to meet the needs of everybody. And given that Hampshire and Isle of Wight has 2 cities, an island, lots of rural geography within it, we do need to make sure that when we build our vaccination centres, they are appropriate for local population need. So we've made a decision to go with 4 vaccination centres. We'll have one up in the north in Basingstoke, and we've worked really closely with our LRF partners, and the fire service have gifted us Basingstoke Fire Station, which is in the middle of being converted to become a vaccination centre as we speak. Moving further south, we have Oakley Road, which at the moment is operational, but as a hospital hub. So it's just focusing on health and social care staff. And as soon as it's given a go live date, we'll flip to become a vaccination centre that looks after the wider population. So that's in process as well. In the Portsmouth area, we'll be using St James's Hospital. That's, again, it's waiting for its go live date and is almost ready to go. And then over on the Isle of Wight, in addition, we will have the Riverside Centre, which will also become a vaccination centre as we get that go live date. In terms of those three components of our model, the hospital hubs, the vaccination centres and our primary care-led model, we are at the moment in receipt of a push model of vaccine supply, which is coming down from the national team. And whilst we can accept that that is creating a lot of tension and frustration at times in terms of people having an oversight of when that supply is coming, how many people they can vaccinate, and people really being keen to get as much vaccine into that local population as possible, for all the reasons I've already described, there is some supply chain constraints in that as soon as that vaccine becomes available in production sense, it is pushed out by the national team into the places that need it most. And so that is very much controlled at a national level. We do need to make sure that there is equity across all of our populations. And what we can't have is some of our areas having already got through all of their over 80s and other parts of the country, for example, who have only got 10, 15, 20% of the way through those groups of people. Because again, going back to our core aim, it's about saving lives and preventing hospital admissions. So we need to make sure that those top 4 cohorts of people are being done equitably across the country. Hampshire and Isle of Wight has done very well. The only headline data point that I've got is that we've got through, I think we're up to about 39,000 vaccinations since start of programme. Obviously a long way to go. We need to vaccinate 1.7 million people within Hampshire and the Isle of Wight as a total population. And we will be producing a detailed plan of capacity, demand and delivery, which we can routinely share with people. So everybody will be able to see how we've reached all of our populations, our Black and ethnic minority communities, others that are at high risk, our pockets of hard to reach communities. And we also now have local government representatives sitting within our vaccinations programme board as well to absolutely make sure that we make all of those touch points available to us and make sure that when we're able to, once we've got through those top 4 cohorts, we know where all of those people are, we've communicated well with them, and we're ready to start putting them into centres or getting the vaccine out to them through our roving model. I think that's quite a lot of information. I'll leave it there and just leave it open for some questions, but just a reminder that I think a lot of our key NHS communication is embargoed at this stage, and we will get that to you as soon as we're able to. Thank you.
Thank you, Jenny. Indeed, that was a comprehensive set of information you've given us. I've got some questions coming up. The first one is from Councillor Dowden.
Yes, thank you, Chairman. Jenny, a thing of concern for me, and it will be for a lot of people out there, you're talking about various cohorts and whatever. Of course, key workers obviously are essential to be vaccinated, because without them we're in serious trouble. But the 2 key workers that I think have not really 100% been considered are teachers themselves, because of course without the key workers being able to go to, if they take their pupils to school, then of course we have, and a lot of schools have had children sent home because obviously the COVID has got in there, or one child or whatever. And the other area, which I don't think we've really considered, is of course the refuge collectors. It is so important that the refuge is continued to be collected. And so therefore within environmental health departments, within borough councils who collect the waste, or in unitaries as well, I think that the refuge collectors should, have some sort of priority, because without them, then we're in serious trouble. Has any thought been given to that?
It certainly has. I think actually I can see Simon Bryant has his hand up, and I think the point you're raising is very much around the kind of purpose and scope of vaccines and from the public health components as well. So I'd quite like to bring Simon in at this moment and then dovetailing behind that. Would that be okay?
Mm-hmm.
Yes, please go ahead, Simon.
Many thanks, and Jenny's right. So the purpose of this first kind of part of the vaccination program is to protect vulnerable life and prevent mortality, and that's through these groups that have been identified, as Jenny said, by the JCVI and those looking after them. So you're absolutely right, Councillor Dowden. There is a need to think about business continuity, but that'll be in the next phase of the programme as we think about those groups that we really need to vaccinate. As you say, teachers and refuse collection staff are key to managing how we further prevent spread of this virus. But I think at this point we're trying to prevent mortality and really serious illness with those more vulnerable, and then the next phase will come through. As you say, teachers are on the list for the next phase, but it is the next phase as we get more vaccine available.
Okay, well, I'm glad to hear that. Thank you.
Next question comes from Councillor Thornton.
Thanks. Just very quickly, I had a few questions by our local residents. They thought people weren't going to get the second vaccine, the second booster shot immediately, and yet we do know people who've had the second injection. I just wondered if that's just because they're already booked in and it was more complicated to stop them than to carry on and do it, in which case you can just say yes. And the other question is that I think there's an important cohort that's been overlooked. There are people who drive people to hospital on a volunteer basis, are helping out with basics banks, etc. I'm to be one of them, so I've declared an interest there. So this is an interest of mine. And I don't want to bust the queue or be ahead of anybody else, but I'm taking people to hospital and to doctor's appointments and delivering food to people who can't get it any other way. Now, at the moment, if I couldn't, it's a problem. But if that rolls out and other people have to stop doing it, then we're going to have a real problem. And I know that the NHS volunteer transport service could not cope without us, good neighbours, etc., volunteers. Is there any plans when it's possible to get volunteers in including the frontline staff? Thanks.
Thank you, Councillor. Yes, of course. So I think just in the first dose and the second dose question, the short answer is yes. Many patients were booked in for a second dose before the guidance changed, and because we set up our services in waves, some of those services obviously went earlier than others. So at the point the guidance was announced, some of our services had lots of time to cancel everybody. Other services had already done some second doses or had some booked in very short timeframes, which are almost impossible to cancel. And for example, if you take our Portsmouth Hospital hub, they had even organised transport for some of their 80-year-old patients to come back into hospital to have their second jab, having done the first one. And the last thing they wanted to do was to be phoning people over a bank holiday weekend, cancelling transport, cancelling things, etc. Having said that, we heard a very clear message from the leadership of the NHS yesterday that, you know, the 1 in 12 dose issue is absolutely not a political thing. It is very much clinical, evidence-based epidemiology advice that says spread the dose further, faster across first dose to give protection to the population, to save lives and to prevent hospital admissions. So it does give us the breadth of scope that we need. So the first dose is very important, no matter how much frustration it does cause. And I recognise that we built people up to have the first and then the second dose, and actually that's creating some confusion and tension. And because not all services did it in exactly the same way on the same day, we've even had examples where, you know, in Portsmouth, where one member of a family was having their second dose in the hospital and the other in the primary care service, and the primary care service said yes and the hospital said no, etc. So there is that confusion on the ground, and we fully recognise that. But I think that should level itself off now, because we've been very clearly instructed no second doses until we've got.
Absolutely, no problem. I totally understand. Yeah.
Yeah, and your second question, remind me your.
Basically, we've got some volunteers who are doing pretty essential work, delivering prescriptions to people, taking people to hospital on a volunteer basis, and delivering food to people for basics banks and stuff like that. And getting people to hospital is more and more difficult, especially if people don't go on public transport, and public transport is lacking. And it's much safer for someone to go to hospital with a volunteer driver from a charity that's people have been instructed how to do it. The person sits in the back, we spray the car with cleanser each time, we wash, all that stuff, right? Than it is for them to try and get there some other way. And when we get to hospital, we respect the guidelines, we help them if they're disabled, etc. And the same with the prescription deliveries. It's really important, and because that keeps people from coming out, going into pharmacies, mixing with other people, standing around waiting for prescriptions. It's much more efficient if we can take it to them at home. And the delivering food for the basics bank. All those are pretty important. You can put them in different lines. And of course, it's not as important as care workers and doctors and stuff like that. But at some point, I think if you don't protect volunteers like that, it's going to cause real problems if we start getting COVID amongst ourselves. And I'm just wondering, obviously, we don't want to be at the top of the list now, but at some point, have you got plans to include them in your definition of a frontline worker?
Yeah, so I think you're right. The definition of a frontline worker could be slightly clearer from our point of view. Some of it is very obvious, and then you get this kind of grey zone towards the end of that spectrum. But what I would say is that if we, at the moment, what we're trying to do is to make a calculation of how much vaccine supply and how much capacity we've got to vaccinate, and how many NHS staff and very obvious social care workers we've got in that space, and in the background keep a list of exactly the services and teams and people that you describe, so that we can be really clear who they are, where they are, which bit of our model will do them when it is time for them to be done, and so that we can then almost form that kind of whole system orderly queue, which is much more defined. So we're trying to do both those things in parallel, so that when that capacity is available, we're very clear who, and we can draw them in the right order. But it's a very tricky position, and I think there may well be some more clarity at a national ministerial level as well, because I think most areas in the country are really struggling with this, and there are some very high-risk groups that appear to be missing from prioritisation, such as people that live in learning disability accommodation, for example, which is coming out very clearly as a group that should be in the kind of care home group. So there's lots of discussion, but very, very much clinical at the moment in the national team.
Thanks a lot. Cheers.
Thank you, Jenny. Next question comes from Councillor Briggs. Councillor Anne Briggs.
Thank you, Chairman. Jenny, with the pressure on nurses and the shortage of nurses and the millions of people who need the vaccination, are you training people to do it? Or who's administering the vaccination?
Sure. So there are a number of specific roles that are set out for vaccinators, but the vaccinator role has been kind of brought forward as a specific role that you can train people to do, which isn't a nurse or a doctor. There needs to be nursing and medical oversight, of course, because there are more complex components of the delivery, like drawing the vaccine down, etc. So there's medicines management handling components which can't be done by non-clinical professionals. However, we can significantly bring forward other components of workforce to do that. So, for example, with the Basingstoke Fire Station, we also have a significant HR process ongoing with the fire service to onboard many of their staff and train them to be vaccinators. We've also partnered with University Hospital Southampton and their NHS professionals, which is the kind of national bank of NHS staff. And so that we're using that as a platform to onboard lots of people. There have been adverts that have gone out on NHS jobs. And so there are many, many people, members of the public, members of other bodies coming forward to undertake those roles. And I think last week we brought online another 197 staff. There are, I think, over 1,000 in the pipeline that are coming through. We do at some point need to just take that step back and say, have we got the workforce in the right place to cover off all of the critical issues that Andrew described in terms of pressure on the NHS versus the benefits of targeting that workforce towards the vaccinations programme. And so that will always be a delicate balance, but certainly, yes, really significant programme of work ongoing. And the more people that we can onboard into the vaccination space means that we can allow, you know, nurses, doctors, others to push much more towards the front line of care delivery, and that means that we can try to keep every bit of the show on the road as we go. But huge programme of work undertaken at the moment around workforce for sure.
Thank you.
Thank you, Jenny. Next member question comes from Councillor Jane Frankham.
Right. Thank you, Chair. One to comment and one to question. The comment is, my son's a volunteer at the centre and they are not being vaccinated. As a mum, of course, I'm concerned, but also it does seem a little strange that they're that that sort of close with people, and they're not being considered. The other thing is that it was reported in the media, which we can't always completely trust, that for someone to volunteer to help who's coming back from retirement, i.e. a friend of mine who's a GP, there is the need of 21 pieces of evidence. Is this true? If it is true, is there any way that can be reduced, because it's putting off people and you need volunteers and people to work of that calibre? Thank you.
So 2 points there. I think just going back to the point about individuals, we must remember again, as I say, the cohorts at the moment is about saving lives and preventing hospital admission. So it's about people who are at risk of being in those categories rather than the importance of their role per se. But in terms of your second point, I think you're right. There has been some clunky HR processes and training events, etc., that people have had hoops people have had to jump through, and the national team have reflected on that, given the amount of feedback they had on that, and there have been some of those things that have been moved out of the way so that isn't the case anymore. But what I would say is that in Hampshire and Isle of Wight, we really are not struggling with people coming forward. That absolutely isn't the process, and it hasn't affected that. Again, by the end of the week, we should have some more concrete numbers that I can give to people for visibility in terms of the workforce numbers that are coming through. But we have the capacity to push people through and to get them onboarded in NHS professionals is the bit that we're struggling with. There's so many people coming forward that we can't get them in quick enough. So we're not concerned about that being a barrier at the moment.
Right, thank you.
Thank you, Jenny. For those that don't know, people tuning into the webcast, we are joined at these meetings normally by the relevant executive members. We've got the executive member for public health, Councillor Grajewski, and we've got the executive member for adult social care, Councillor Fairhurst. And I think Councillor Grajewski wants to say something. Judith?
Yes, thank you, Chairman. Just a couple of questions. Firstly, you mentioned 4 vaccination centres, and I'm afraid I missed the second one, the one between Basingstoke Fire Station and St James's Hospital. And also, in terms of the vaccination, we've got these centres. My understanding is that pharmacists may also be deployed to administer vaccinations. I know this is still work in progress, but I just wondered what the split is going to be, or whether most of the vaccinations will be expected to take place at the 4 centres. You mentioned 1.7 million people trying to get up to 3,000 a day. The maths, according to my calculator, means that's 566 days. So I just would hope that there's going to be some realistic messaging, because I think people's expectation is that the vaccination's around the corner, and once we've done all the over 80s, we're all going to get vaccinated and life's going to go back to normal. And that is not a realistic position. So I think it is important to manage people's expectations early on. Thank you.
Sure. Thank you very much, Councillor. One thing I would say with those calculations is I think it's important to remember that there are way more components to the model than the vaccination centres. So 3,000 a day is the capacity that's provided within the 3 vaccination centres, as opposed to the entirety of the model. We also have the 39 PCNs and the 4 or 5 hospital hubs that are in place. So their capacity is far greater than that. And also the model has the capacity to stretch sideways. So if we wanted to add, 1,500 a day here or 1,500 a day there, we have the capacity to do that, but we need to see where we're doing better than, worse than, make sure that we can move our assets around to make sure we cover off the spread in the population. So I think that's one point to note. In terms of when people are going to be vaccinated, the modelling data is very much held at a national level at the moment. So, and because we're kind of in receipt of the vaccine that we receive, and we've got the model in place, our operating model at the moment is very much to just crack on with the populations that we've got and to get through it as best we can. I think pharmacies are going to be a helpful component of the model, but a very small one. So if you imagine in a pharmacy flu vaccination clinic, they would do 10 people in a day, possibly 10 or 12 people, and we need to be very clear that we don't waste any vaccines. So disseminating vaccine to lots of very small pharmacies could potentially be a risk. But having said that, we do have pockets of the population that aren't due to be covered by the model that we've got. So we want to be able to use those components to absolutely be part of that. But our pharmacies will dovetail in and work with us to make sure that they do that. And so, of course, working with the AstraZeneca vaccine is probably more beneficial for them than working with the Pfizer one. But we do need to lean on our clinical colleagues to help design the programme in a way that means we do all of that. We keep everybody safe, we don't waste any vaccine, and that we don't don't make sure that there's nobody coming forward into that space to actually be in receipt of that vaccine. So we need to make sure it's as efficient as possible too. And your other point was you missed one of our centres, which is Oakley Road.
Where's that?
Southampton.
Oh, right, okay.
Southampton, Portsmouth and the Isle of Wight, spread across the county.
Just to come back, I'm glad you mentioned the limited capacity in community pharmacies. I've got personal experience myself there and understand how pretty overworked pharmacists are generally, and they will not have the capacity to deliver large-scale vaccinations. But the other thing that you mentioned, and it's been touched on in numerous presentations from the government and their advisors, is the rate of supply, the supply chain concerns. And I haven't heard yet just how many vaccines are in a batch and how quickly it can be produced, because this to me seems as if it's going to be the rate limiting factor. You don't want lots and lots of volunteer trained vaccinators if you actually haven't got any vaccine to administer. And I wonder if you have any comment on that, or maybe you're not in a position to comment at the moment. Thank you.
Yeah, I'm certainly not in a position to comment on the numbers. I absolutely concur with the national team in the sense that, you know, as the supply is made available to us, it does need to be pushed into the places where it's most needed most. And I think that having a view of that on a national position is very helpful, because it means that we do prioritise it into the right communities at the right pace. I think it's not a limitation in the supply chain. It's just being produced as fast as it possibly can be, and central government have procured, you know, enough for our population. I think what we need to understand as the capacity comes online is what does that mean in terms of end date, so that we can then give all of the right messages to everybody. And I think having some headlines come back that are, you know, roughly telling us when the programme is going to end, in the sense that the whole population would be done by X date, whenever that is, gives people a real sense of not knowing, as opposed to kind of being clear about roughly where they would be in that process. But we are assured there is enough vaccine to vaccinate the whole population coming, and we just need to work with the national team and just make sure that we've got all of our capacity ready to receive and our patients lined up, and that they're the right patients going back to the saving lives and preventing hospital admissions, until we can be more nuanced about that once we've achieved that aim.
Thank you, and thank you, Chairman.
Thank you, Jenny. Right, last two questions. First one comes from Councillor Cynthia Garden. Cynthia.
Thank you very much, Chair, and thank you, Jenny, for all that terrific information. My question actually is very similar to Judith's regarding vaccine delivery. Now, by what you're saying, I understand it's being managed nationally rather than locally. So can I ask, you were saying about the vaccine getting to the right people at the right time. How is that managed with the different surgeries around Hampshire? Do they apply? Do you know if they're running out, how much they need, how many patients they have in a certain category? I'd just be interested to know, please. Thank you.
Sure, thank you, Councillor. It's a really good question. And I think one of the things that the NHS benefits from in terms of its internationally, I think actually, is the GP practice list. The GP practice list and the fact that we have an NHS which is free at the point of delivery, which means we know exactly who our population are at all times, because 99.99% of the population is registered on a GP practice list, and we have all of that information. So you're right, it is a push model. We are in receipt of deliveries as per the national team's instruction. However, they are very clear that they have all of the data they need to know what proportion of over 80s population each GP practice has, and then how those primary care networks are working together at scale to make sure that they vaccinate the over 80s population. So for some of our GP practices, for example, up in the north of the county, they have really come together, quite a few of them, to work in one place to vaccinate as many people as possible. So I think, and then in other places it's been smaller. So they'll have smaller deliveries, that section would have larger deliveries or more frequent deliveries, but absolutely the vaccination deployment is based on proportion of population that has, you know, over 80s, etc., within those cohorts. So it's very much targeted. And all of our GP practices are formally linked with care homes. So we know which care homes across the whole of Hampshire and Isle of Wight are linked to which GP practices. So that data is known at a national level and is part of the model that pushes the vaccine out.
Thank you. Thank you, Jenny. Last question from Councillor David Keast.
Thank you, Chairman. Good morning, Jenny. How are sheltered accommodation being treated? Are they being treated the same as nursing homes, or are they just being treated the same as the general public, please?
So I think, again, it goes back to the points that that Simon made and myself around the kind of the purpose and scope of the vaccine. So whilst sheltered accommodation in itself isn't a high-risk environment like a care home is, but the people who live in sheltered accommodation would likely be over the age of 80. So if they're over the age of 80, they will absolutely be in that first 4 cohorts. But being in sheltered accommodation doesn't necessarily make you at risk in those first 4 cohorts of, you know, of dying of COVID or being admitted to hospital. So I think it goes back to those clinical definitions. But absolutely, yeah. And if people need us to go to sheltered accommodation to deliver it in model terms, we can build that into the model as part of the roving service as the AstraZeneca vaccine comes into play, because that's how we'll do our homeless communities. That's how we'll take it forward in places for housebound, etc. So anybody that can't come to the vaccine, we will take it to them in those environments.
Thank you.
You're muted, Councillor Huckstep.
Quite right. Sorry, caught out. Councillor Carew, I noticed that you wanted to ask a question, but your hand wasn't up at the time, and I wanted to make Councillor Keith's question the last question, because we still have to hear from Frimley. Can your question wait till then? Councillor Carew?
Chairman, I'm not sure really whether it can, because it's about my neck of the woods, so I'm not sure whether that would be covered under Frimley, to be honest.
Is it a question you can ask by email later?
I'd rather ask it in public, to be honest.
Okay, then we'll go ahead quickly.
I'll be quick then.
Yes.
Okay.
We're about 50 minutes behind on our
Noted.
schedule.
Chair, thank you, Chairman. Jenny, you've mentioned about the 3 rather than 4 vaccine centres in Hampshire, the other being on the Isle of Wight. What are people in the east and the centre of Hampshire supposed to do? I think in reply to somebody earlier, you may have mentioned that there were other forms of rollout, but I'm particularly concerned, given the parlous state of our public transport, particularly in my division, and what are sort of 80-year-olds and people perhaps who are incapacitated or have no private transport, what are they supposed to do in order to access this vaccination, please?
Thank you, Councillor. So are you able to just tell me which is your geography? Apologies, I don't know.
Yes, yeah, sorry, no, I'm in Whitehall and Borden, so Chase Hospital area.
Okay. So we do have up in Basingstoke Fire Station is very close to that neck of the woods, and we also have the Apollo Hotel. What I would say for people who are housebound, as I said, we will take the vaccination to people who are housebound. We also have a task and finish group which has been set up, particularly around the north of the county, to look at transport solutions to make sure that the volunteer networks and all of our transport partners are working with us to bring people to those places. And there is also a discussion ongoing at the moment, which is between the pending vaccination centre and the local GP practices, to see where they might want to do outreach clinics. And so, for example, in Alton or other places, there may well be, depending on the population modelling, stand-up clinics which we could draw people to, which would be very much more local. So that's absolutely all in train, depending on what the data shows us.
That's brilliant.
Thank you, Jenny. Now, at this stage, I want to thank you very much, Jenny, for what you have been able to impart to us this morning. We need to go on now to the presentation by the Chief Operating Officer from Frimley, Dan Bradbury. Dan, are you there?
I am indeed. Good afternoon, or good morning, Chair. Can I just share my screen twice, just to give the first time to give some context and stop me switching around, and then I'll go to the presentation. Can I just confirm how long I've got before we start, because that'll affect the speed at which I talk and brief.
You've got as long as you need to take.
Right. Okay.
You should be concise. Thank you.
Concision will be marvellous. Okay, we can probably do that. So let me just pop up the. So the first thing I wanted to do, with your permission, Chair, is just show everybody the rate of growth that we're seeing in our area of activity. So if I just share firstly this screen. This is the national. You should all now see a map appearing on your screens at a various rate depending on the speed of your internet. And this is the national chart, which I've zoomed in onto our area of operation. So just for context, the white line here is the M25. This is the M3. Basingstoke is here. Winchester is here. And my area of operations broadly runs here across the north of Slough, Maidenhead, down through Bracknell, Fleet, and down past Farnham, across and back up again. So broadly taking in that area, but I've tried to contextualise it. This shows the rate of community prevalence of COVID, and the darker the blob you see, so this blob is between 400 and 800 cases per 100,000, and clearly the lighter the colours get, the worse the prevalence gets. And I'm just going to quickly show you the rate at which this changes over the last 4 weeks. So assuming that my map is catching up with me. So you should all see, so this is now 2 weeks later, mid-December, week 3 of December, week 4 of December, and the current position. And what you can see in my area in particular is just how rapidly the rate of transmission has changed. And that would affect the Hampshire district, particularly insofar as this area around Hook, Farnham, Aldershot, this area here on the M3. And you can really see that rate as it changed. So I just thought that was some useful context in terms of why Frimley has been so greatly affected. If I now flick to my presentation, and you should now have something with winter pressures, COVID-19 and strategy update on your screens. So firstly, sorry, go on. So firstly, I wanted to just say that we went into the winter anticipating a level of COVID activity. We knew that was likely to come. We thought a second wave was likely. That follows previous pandemics. We've perhaps seen the rate of increase of patient admissions rise faster than we were anticipating, but we had a worst case scenario, which fortunately we've been able to roll out. So first of all, what have we rolled out in terms of just managing all of our demand this winter? We have done some work on NHS 111 and First Care. So what this means is that patients who are feeling ill are being encouraged, rather than to phone 999 or just to turn up at the hospital, are being asked to phone 111. What that means is that where they are not urgent, we can book them into the right place. If that's a GP, we can send them straight to the GP. If the emergency department is the right place, we can book them in there at a booked slot. So we can book them in and hopefully manage some of our demand rather than it all arriving at peak times. More importantly, though, it's been able to allow us to book patients directly into the right area of the hospital. So if they're clearly, for example, a gynecology complaint or a medical complaint, we can book them in. So that instead of going to the emergency department, they go directly to that department. The numbers are still small, 20 or 30 a day on each of our acute sites, but they are growing. And we definitely think that as this programme grows through, well, probably from April onwards now, we'll start creating more space to do this in and upgrading our triage, upgrading the areas, but also expanding the range of services we do this for. So there's a real opportunity there in terms of how we manage our demand, even in normal times. Flu vaccination's been really good. As at 3 weeks ago, it was at 72%, which was significantly ahead of many hospitals and particularly where we were last year. And I think the COVID has, increase people's willingness to turn up and be flu vaccinated. Coming on to COVID, and I'll probably freestyle because both some of the comments that the previous two speakers made, I'll give you some local context, but also to update you, I would absolutely agree that the situation is changing rapidly, and therefore the brief we submitted several days ago has already been overtaken by events. However, it is absolutely the case that we had detailed plans for our second wave, and we knew roughly when it was going to attend and what sorts of numbers were likely to emerge. The rate, however, has taken us slightly by surprise, but again, because we have these detailed plans, we've been able to manage. The second strain, which has come online recently, has been an issue for us. We seem to have seen patient zero in Kent, and the route, as you will probably have seen from the maps I showed you, they seem to have gone into London, but also come round the M25, and we've definitely seen a good spike of our admissions and attendances have been as a consequence of that strain. One thing to note about it is significantly more infectious, so we think that's driving some of the activity. And that one of the reasons, because that flow round from Kent down the M3, is that Frimley Park has been significantly more affected this time than the Wexham Park site has in the north of Slough. Last time we saw a much faster rise in Slough, and then a few weeks later we saw a more gentle rise to a similar number in Frimley, and it's been completely reversed this time. The high levels of infection, as you can see from the map, have been particularly in Slough and now in Rushmore taking off, and around the Aldershot area and Farnham have been particularly high rates of growth. And that's placing a lot of the Trust's activity under severe strain. And we've got plans. So we would reflect much the stuff that Andrew talked about earlier in terms of we reduced and postponed a significant amount of our elective activity, and we have now retrenched onto urgents and cancer activity only. We've also been able to work with the independent sector, so we are now setting up a hub so that we have 2 treatment hubs, very small treatment hubs left on Frimley Park and Wexham Park, and we're working to open a treatment hub at Princess Margaret Hospital in Windsor, which will allow us to continue some of the cancer activity. To give you some numbers, it says here in the brief that on 6th of January, we had 612 COVID positive inpatients in the Trust. It's probably worth noting that on the 11th of December, so a month ago, there were 110 patients in the Trust. So that's been the sense of the rate of growth. Over the last 20 days, that grew from 110 to 527. And then over the last 10 days, we've grown another 150. So you can see all of the growth has been loaded into that period in the 2 to 3 weeks before and around Christmas, and that rate has slowed significantly. And we're not sure why. It's not because we don't know whether it's because we reached a level of prevalence that everyone else is now catching up with, and we just got there early, or whether it's because we were unlucky. I don't think that's the case. Or whether it's simply a question of the prevalence was already there, but because Slough was in lockdown early, it transmitted less. So there's that difference between transmissibility and prevalence, and we're just trying to work that out. If I just go on to the next slide, this will give you a sense. So going back, if I just follow my mouse, so that's the wave 1 climbs the peak and then the tail. And then if you look, so this comes to the end of this, the end of 2020, the significant spike. So both a steeper spike and a significantly more larger increase in growth rates. And the key to the map is grey is inpatient attendances, blue is positive tests, and red is daily deceased. So from that number there, we've probably added another 50% on top of that number to get us to our current 694 as at this morning inpatients. And again, this chart shows daily positives and admitteds for COVID-19 that focused on one of the sites. So just a different way of cutting the same data. What we're doing at the moment is we've been asked to engage in a planning exercise by NHS England about a worst case based on the rates of growth that they've been seeing in London and Kent. And as I've said earlier, I think we've already seen some of that rate of growth. So what we're now working on is a reasonable worst case scenario. It's likely, based on the current rate of growth, that we will add probably somewhere between 250 to 300 inpatients to our current load. So we think we'd see that probably at some point in the next 7 to 10 days. Again, we've identified areas that we can do, and for us the critical issues now about how we work with our system partners to accommodate that, and what more elective activity we may need to reprofile in order to create the space to do that. So our planning process has been broadly right. What's been interesting clinically is the demand on non-invasive ventilation and our intensive care units. Andrew mentioned earlier that he's been taking patients from other sites. We've been one of those sites that's been doing mutual aid to Hampshire hospitals and around the country. We've been required to send a couple of patients as far as Bath, but that's been able to allow us to safely have an escape valve for our intensive care patients, which has enabled us to manage that load at the moment. My intensive cares at the moment, normally they run at 24 patients maximum capacity of all types. At the moment, they are both running at a total of 48. So we're at 100% more of our normal intensive care load than we would be. And for non-invasive ventilation capacity, we're running at a similar number. So there's no doubt that demand for higher acuity services has been significantly affected. We've been working on our testing system. Again, a couple of the questions that I would pick up about screening. We do test people on admission in common with every other hospital. But what we're finding is that patients who are admitted for non-COVID reasons are sometimes being admitted with COVID, but not with it, but an early enough stage of the progression of their COVID that it's not picked up on the tests. So we are now testing people on day 1, day 3, and on day 6 of their admission. And that's where some of this inter-hospital transfer is coming on, because you're trying to cohort people, but what you don't have is the absolute evidence that people are safe. And at the moment, the number of side rooms, so single occupancy rooms that we have, does not allow us to put people in those rooms until we know for certain. So there are some genuine resource and geography constraints. Vaccination, you've heard much tell about this in terms of it being the light at the end of the tunnel. Pick up some of the questions, we started this with everyone we could lay our hands on. What we're now doing is being a lot more prescriptive about if you don't need to be running your outpatient clinic, then any consultant is perfectly capable of administering an injection. So we are working through the process now of saying, okay, if we're not running routine injections in, let's say, ENT or dermatology or something like that, you can reuse those staff, and that frees up nurses who might previously have been giving vaccinations to do things that only they can do. So for us, it's now about skills as much as qualifications and professional groups. As at yesterday, we had administered just shy of 10,000 vaccinations. We submitted our brief about a week ago. We were at 6,500. So we're averaging at the moment just shy of 500 vaccinations a day, based on much of the same profile and prioritisation that you've heard about already. Before I go on to the strategy, I'll just probably pick up a couple of points about that you've taken questions about. So for us, we have the same constraint around oxygen as Hampshire hospitals do, which is that we are getting more than regular supplies. We absolutely cannot fault the supply chain. For us now, it's about hospital plumbing and the ability to move vast quantities around the hospital. Because the oxygen is supplied in liquid form, it's clearly, what's the right word? It's turned into a gaseous form in a piece of equipment. And that's now having to be defrosted 4 times a day, because the rate at which we're using it is starting to freeze up some of the pipe work. So we're just having to make sure there's a whole load of extra processes you have to put in place to make sure that the volume of activity you've got can be sustained. And we're working with our national colleagues who've been supremely helpful to work around that. Staffing, as with everybody else, staffing has been our major concern. So again, once you start slowing down your activity in your operating theatres, you can reuse some of those staff in intensive care or high care areas, and you can also free up some of your outpatient staff to work on the ward. So for us now, it's about what activity we can sustain in order to safely staff all of our ward areas. And then in terms of the independent sectors in our areas, there are 3 major providers, 2 from the Spire and 1 from BMI, and we're using 2 of them to help us manage our inpatient load, and 1 of them to try and keep our cancer services, because we can centralise everything there. And they have been helpful, but we were one of the first trusts in the country to have to ask for extra support and to work with our independent sectors to work outside the contract for surge capacity, to use them for medical patients rather than for elective activity, which is how they're being used in many other parts of the country. And we've been really well supported in doing that. If I just go on to what's coming next. Despite all of the current pressures, we've still got to look forward to the future. And in some ways, some of the pressures and the way we've reconfigured our services have allowed us to look afresh at the way we might want to be doing things over the next few years. So we are still working on delivering our hospital strategy, because we think that's potentially a good vehicle through which we need to deliver the recovery process from COVID. There are 6 key ambitions: quality, supporting our people, particularly important at the moment, working with our partners at a more system level, transforming our services, clearly making the finances work, and then advancing our digital capacity. And each of them has got clear objectives which will allow us to take our activity forwards. Those break down as follows. So we've got some clear ambitions. So in terms of quality, for example, we want to be one of the top 10 trusts in the country for safety and for patient experience. If I come through to digital, we want to be one of the top 10 digitally advanced trusts in the country. And in my own area where I lead in terms of transforming, we want to provide consistently excellent care. So we're just working out now, what are the lessons we have learned from wave 1, the recovery, and as we go through wave 2, that might allow us to run our services in a different way. In 2025, we've got a clear look forward, but we will have a completely rebuilt Heatherwood Hospital on the Ascot site, which will allow us to have a completely elective site. We're trying to have a 40% reduction in falls, 25% reduction in serious incidents, and implementing the National People Plan, which is around psychological support, well-being, but also inclusion and diversity to make sure we get the best use of the talent available to us. Collaborating with our partners, and you've probably already picked up some of the themes there. So 111 First clearly affects us, primary care, the ambulance service, our community partners, and we want to make sure that this is a whole system effort rather than it just being something that we, the trust, lead on. I've talked about Heatherwood, but having the right operating model at the Heatherwood Elective Centre will allow us to configure ourselves to meet our future demands, but also having pathways that have as few touches as possible for patients. So, for example, in gynecology, one of the ways they've been working is that every patient is offered a video appointment first. By doing that, it means that we've taken a full history, so we only have to do that once, but most importantly, we only refer them into the right services and the right tests. And we can do all of those follow-on tests then in the shortest space of time and the fewest visits, which is then more convenient to patients. Now, once they've had those tests, if it's simply a question of you need to go and see your GP to be prescribed the following drugs, you can then do that remotely rather than having to bring the patient back for another hospital appointment. So working in a better way to the benefit of the patients. And then finally, it's probably worth flagging up, we've just ordered an electronic patient record, which will significantly update our patient information services. We're buying a product called Epic, which is recognised as one of the best systems available, and it will be designed bespoke for us. So it's a really promising and exciting development for us that will come online at the end of 2021. That probably concludes the sort of formal part of my brief and some of the points I wanted to get over. There's then a question of whether there's anything you want me to pick up in questions.
Thank you, Dan. That was a very comprehensive insight into what goes on at Frimley Health. Thank you very much indeed. I've got a couple of questions. First one is Councillor Carew.
Thank you, Chairman. Sorry about that. You mentioned, I think, that there was an issue you said about capacity or potential issue about capacity and staff if the current pernicious virus gets worse. At what point do you ask whether you call in help, for example, given the co-location, perhaps our armed services could be used to help administer vaccines? Is that something that's been considered?
If I can take that in 2 parts. So first of all, the armed forces, we don't, sorry, I probably should declare an interest of my own, which is that I retired as a Lieutenant Colonel 4 or 5 years ago. So I probably speak from a certain level of knowledge. So we don't have fully staffed field hospitals sitting around waiting for the off. They work as an integrated part of the NHS, and then as required, they're drawn into service. So at Frimley Park, we already have a fairly substantial military unit, which is embedded in the unit, particularly around trauma, orthopaedics, the emergency department, those sorts of things, and anaesthetics. And those people are fully integrated with our workforce now, and actually a very valuable addition. So for us, in terms of vaccination, I go back to my point about it's about the right skill set. So the armed forces and others are already working on the wards delivering the higher ends of care because that's their skill set. And so for us, it's as we have to draw back, as with any other hospital, on our normal activity, our outpatients, it's about reusing the right members of staff to keep the vaccination programme going as we do that. So does that answer the question?
Thank you, Dan. Next question is from Councillor Cooper. Councillor Rod Cooper.
Thank you, Mr. Chairman. Good morning, Dan. It's nice to see you. I've got quite a few actually, so if you will indulge me.
I saw your hand up early.
Sorry?
I saw your hand up early.
Yeah. First of all, congratulations to Tim Ho on his award, well deserved, by the way. You're quoting figures of 694 in the trust of inpatients at this moment in time. Can you break that down and give us an idea of how many of those are actually Frimley? Because I think the Frimley ones are the relevant ones to the area of Hampshire.
Yeah, so for us at the moment, there are 270 in Wexham. There are, it's around 60, it varies by the hour, in the community hospital at Farnham, which is run by Frimley because we provide the community services, and the remainder are in Frimley Park Hospital.
Okay, thank you. The other thing that you was in your presentation there is there are plans for a vaccine centre in Frimley. Is that actually going to be in the hospital itself, or is that going to be an off-site? And when do you envisage that happening?
The short version of that is, and the honest answer is, I don't know. We're just working through the detail at the moment. At the moment, we're trying to keep as much stuff out with our primary care partners, but we are going to need to set something up, if only to make it more convenient for our staff. There are some technical details about the number of times you can move the Pfizer Vaxxer around in its frozen state, and then how far you can move it onwards, which has meant that we've had to use Wexham Park as the site from which we've done all of our staff vaccination. I can follow up and get you an answer offline if that would help.
Yeah, thank you for that. And also, one of the things you mentioned there is the cancer, which of course is very, very important. And I correct me if I understand from your presentation there, you're going to move that up to Windsor in the short term.
So we've got we were required to postpone some of our cancer surgery last week, which we've been able to reschedule this week. We have a completely segregated pathway in Frimley Park Hospital, which is doing cancers today. So we're keeping that on the acute side. And then there is a similarly green pathway, which is doing the same work in Wexham. And then we're also setting up a cancer pathway in PMH, which will do some of the work that we would normally have done in Heatherwood Hospital, such as the breast work, the gynecology, and some of the less acute urology work will be done there, thus freeing up Heatherwood Hospital. So it's a moving feast because it depends. If we have more than about 20 or 30 more demand in Frimley Park, then we'll need to see what else we can move or to reschedule it again, whether patients will need to be offered different treatment pathways. So it's something that changes by the week.
Lastly, especially around the London area, there's been a lot of talk that hospitals are in crisis. Are we anywhere close to that, or do you think that we're going to be able to ride this storm with the modelling and the predictions that you've done?
So I'm confident in the plans that we've got and the plans that we're developing. I don't think I'm going to be drawn on the crisis word. There is no doubt there's been a significant amount of pressure, and that's taking its toll on our staff, who are tired and in some cases having to self-isolate, which reduces the pool that's available. But at the moment, we are able to cope.
Thank you very much, and it's been a really good, comprehensive presentation, and it's good to see you at this meeting.
Thank you.
Thank you, Dan. Last question from Councillor Jonathan Kenty.
Thank you, Chair, and thank you, Dan, for all the work that you're doing to care for our residents in Farnborough and Aldershot to this point in time. Just a couple of questions from me. It'd be good to get a sense of what the age range is of patients who are being currently treated for COVID-19 within Frimley Park Hospital. Certainly within Rushmore, the data suggests that there's quite a strong correlation between a spike in cases amongst the over 60s and the spike in cases overall. Secondly, I totally understand that the focus and priority at this time is on tackling COVID-19, but my question is, what support and communication are you providing to patients who are potentially facing a longer wait through elective care operations, whose physical and mental health may be at risk of decline through that longer waiting period?
Okay, so yeah, two separate questions. The age range, we're seeing increases across all age range. It's interesting that about a month ago, when I've said it was primarily those who are 60 plus, we're now seeing many more patient presentations, particularly down into the sort of 35 to 40 range upwards. So there's no doubt it's shifting into a younger cohort in terms of presentations. In terms of managing our electives, clearly, as we talk to patients when we've had to cancel or postpone particularly their outpatient avoidance, we've been offering them a number to call. Last time, the consultants were able to maintain contact with particularly those who'd waited a long time remotely, and we're just looking at how we can make that available. But I think it may be a question of patients making contact with us rather than us being able to do it proactively, just because of the volumes involved. For me, in particular, I think we prioritise once a week all patients waiting for surgery of any kind. So P1 must be operated on broadly within a week, P2 within a month, P3 is within 3 months, and 4 you have a little more latitude. And particularly for the P2s, which involve some of the most urgent cases that aren't coming in as emergencies, we are making contact with those patients in particular because we're trying to keep them informed in terms of when they may or may not be coming in for their surgery. And if we try to work out whether there's a more suitable treatment pathway, particularly in terms of cancer, we're keeping them informed in terms of that as well. So it is a thing that's constantly ongoing. But I couldn't promise you that every single patient has been phoned just because of the volumes involved. So we're trying to focus on the high risk, high priority ones.
If I can just follow up on that, are you seeing any evidence that the patients who were previously categorised in categories 3 and 4 are having to be escalated to priority 2 because of the length of time that they've been waiting for treatment?
I couldn't say, because in some cases the same obverse may also be true, that patients who've been reviewed would be deprioritised as consequence of that weekly review. So I think there will be some movement around the margins, particularly of P2 to P3 and P3 to P2, but the numbers won't be large.
Thank you, Dan. Thank you for all the information you've imparted. We will now conclude this item. I'd like to thank all the NHS personnel who were able to contribute to it, because it's been very informative, and we have taken longer over this than we would have anticipated, but I think it was important that we heard everything that was to be offered. So thank you all very much indeed. We've all been screen bound now for the best part of 2 hours, so I'm going to have a break, coffee break, leg stretch, whatever, and we'll reconvene at noon and follow on with the agenda. We are roughly 45 minutes behind the schedule I outlined at the start, so you may need to reorganize your timing. So thank you very much indeed. Marie, can you tell us when the webcast has been closed down? Right, welcome back everyone. We just need to finish off formally item 6, and that is to deal with the recommendation. The recommendation was to note all the reports that we had. Is it agreed that we note those reports?
Agreed.
No dissent. Agreed. Thank you very much indeed. So now we can formally go to item 7, which is the public health update. And we'll be receiving a presentation from the Director of Public Health, Simon Bryant, who'll give us the latest update on COVID-19 from a public health point of view. Are you there, Simon?
Good morning. Yes, hopefully you can see me.
I can. Good afternoon.
Oh, good afternoon, sorry. I will just present some slides if that's okay, Councillor Huckstep.
Yep. Yes, please.
Are they on screen now?
They are.
Brilliant. So I realise time is tight, and also you've had a number of updates. So I'll just give a quick epidemiological update of where the virus is, and happy to take questions is probably the best way to do this. You can see here the increased rates across most of the England region, particularly in London, east of England and southeast. But this map on the right hand side shows that the higher rates are really across the whole country. With regard to COVID. As I say, I'll canter through quite quickly and happy to pick up questions at the end. And you can see with regards to South East region that all our areas have very high rates, well over 400. And if, as with plenty of those have come from the east, where we had that new variant starting off in Kent and some other parts of the country and spreading out fairly quickly, and we can see now that's hit the New Forest last week. New Forest had a slightly lower rate. When we look at our district rates, you can see Rushmore being the highest, followed by Hart, and increasing rates everywhere, and that's reflected across our kind of neighbouring areas as well. So a really concerning picture. It's worth saying, don't just look at the rates. All the rates are kind of going up. Some are slowing down in their rates of increase, but they're all going up, and we need to be really mindful of that. Lockdown should really start to reverse that in the next short amount of time. Across our, I like the phrase, ceremonial Hampshire, you can see that Portsmouth has had cumulative the most number of cases, followed by Southampton, and then Hampshire, sorry, rates, and then Isle of Wight is creeping up very fast at the end there. And then if we look at our cases, we can see most recently we had 1,652 cases in a day. This is across Hampshire County. The rate here of 35% increase in the last 7 days is actually less than it was when we looked at this last week. So again, a little bit of a glimmer that it's slowing down, but again, we're in a very difficult position with increased casing across Hampshire. And so far, there have been over 40,000 cases of COVID detected from the start of the pandemic. And then I think someone was mentioning some of the rates, and these are the 7-day rates, and you can see the increase across all cases, and particularly thinking about, let's go back, Rushmore here, and then Hart has increased, but all areas you can see are increasing. And the 7-day rates here on the right hand side, you can see our rate in Hampshire is 575 per 100,000, and compared to England, slightly lower and South East. But London has a rate of 1,000, which is what we discussed earlier in terms of the Frimley presentation. And again, Rushmore has got the highest increase rate, with Hart following closely behind. And we can talk a little bit about why that might be and what we do about that. And then when we add in the over 60s rate, a really important rate, because we know that these people are more likely to be seriously ill and be hospitalised. And yes, we're right that we've heard that other ages can be hospitalised, but this is the age group that's most likely to be impacted across the piece. You will notice some of the dates are different depending on the date the data comes out. So really, it's looking at the trends going up there. And they say they're all in an upward position. When thinking about age groups, you can see over the course of the pandemic, the darker kind of, as my colleagues like to call it, the bruise colour, is really in this age group here, the 15 to 64, and then the 85 plus. So you can see that real spread of virus. We know that the 15 to 64s are those who are out and about working maybe, and then the over 80s are the ones who are most likely to be impacted. This has been updated from your presentation this morning, but you can see the trend graphs there and the number of people in hospital with COVID across our Hampshire and Isle of Wight patch there, with particularly that conversation about Frimley and Portsmouth we've seen. So high rates of hospital admissions, and we know that winter's difficult. There won't just be COVID patients in those beds, there'll be other people that the hospital is trying to manage. And then we're looking at mechanical ventilation, and again we heard from Frimley and from the Hampshire and Isle of Wight system. They've increased their ventilator beds by 100%, so 300 patients on ventilators does not take into consideration the capacity, which would be considerably less, but they've increased that due to the need to increase the care for those on critical care units. And then when we look at excess deaths, we're still getting deaths from many other causes and COVID. We're still under the 5-year average. However, I think we're getting close to that in the later data. So we need to really think about how we manage our excess deaths. And sadly, over 1,000 people have died of COVID in Hampshire, really sadly. And obviously dying of other things as well. But COVID is increasing with 36 in the last week. The tiering that was being brought in, and I think I presented before, this summary slide, which I've asked Marie to send round in the pack, and I'm sorry, I do write these in the morning of the HASC so that actually it's really up to date. We can see we've got case detection rates high everywhere, and over 60s rates higher, and they're going up. And our positivity rates, so the number of people who are detected as positive from the percentage of the test taking, because that shows basically if you've got symptoms, they're not always COVID. And we can see really high positivity in Rushmore and Hart. And actually, sorry, the New Forest has just changed. Again, they're all going up. And we need to, it shows this really concerning picture of COVID across Hampshire. A little bit about the new variant I thought would be useful. Here's the southeast. We look at this on a southeast basis with some analysis, and we know that across all of our districts, the new UK variant is present. So this is showing the UK variant, which is much more transmittable. So it's about 70% more transmittable than the previous variant of COVID, but it doesn't necessarily give an increased severity of disease as measured by hospitalisation. However, the South African variant, which we've also been concerned about, does have a higher viral load. So we're just looking at what that looks like and whether that is going to give more severe disease or worse outcome. So some real concerns there around this new variant, and that's what's caused this huge rapid rise in spread across the country, but particularly in the southeast. And it's got a very strange name. We don't tend to name them after places or just because that's not the etiquette. A couple of slides. I won't talk about vaccination because we've had a lot of presentation on that. I wanted to just update you on testing. You'll have heard and seen in the news over the weekend that community testing is available. We are, as we have moved into lockdown, that is available for us to develop. We are doing that plan, developing that to ensure that we can appropriately test our communities to help them understand their disease status. We need to be really careful with this because the test is about 60% accurate. That's really good, but that might mean you test negative when you're positive. So we need to use it in the right setting and the right way. For example, we can't have people taking off their PPE or not social distancing or meeting again on the basis of that test. It just helps us to help identify people early so they can manage social distancing and isolation. We've got some targeted programs for adult social care and other sectors, and it was announced this week again, blue light workers, so fire and police, and all front-facing workers will be tested. And as you know, that was announced very rapidly last week. We are developing those programs now. Really positive, but it's not the answer yet to preventing this pandemic. So key messages, I have cantered through quickly for time. We know it's sharply increasing across Hampshire, and we've got an increasing R rate. and we know that it's bringing patients into hospital, as we've heard this morning. We know the new variant is spreading, and about 65% of cases are attributed to the new variant. We're in lockdown. We must follow that advice, as Professor Whitty said. Act as if you've got the virus. We all need to follow that advice to stay home and only go out if we need to, because actually that is how we will control this virus, and that will then prevent spread furthermore. So Councillor Huckstep, I'll stop there and very happy to take any questions.
Thank you, Simon. That's very helpful. Would it be possible at this stage just clarify some technical points? I think everybody understands the R number as a metric. A couple of other terms have crept in. One of them is transmissibility. What's the metric of that exactly? Is it similar to R, or is there some other esoteric definition? And you've also introduced viral load today as well. Can you just explain exactly what that is for?
Yes, of course.
Everybody who's listening in.
So the R rate shows how quickly the virus spreads. It's a measure of spread. So I guess transmissibility is the kind of methodology of how that happens, and then the R rate is the final measure of how fast it's spreading. So if something's able to transmit quicker, it means that it can pass from person to person more easily, which then puts up your R rate. Viral load is a term around how much virus is in your body. So actually, you know that you can get an illness mildly or more severely. Sometimes with a higher viral load, you're likely to be more severely ill. With the new variant, not the South African one, the English one, we know that it transmits quicker, but it doesn't necessarily have a higher viral load. So you can get the virus quicker, but it doesn't increase the amount of virus you have in your body. Whereas it looks like the South African one, you are likely to have more in your body because of the way it's spreading. So yeah, sorry, that's technical. I'm sure I can provide that in an answer if that's helpful.
Thank you, Simon. That's fine. What you've clarified is that there isn't really a metric for transmissibility. It's simply that it translates into a higher R number. Okay. Now, the other thing is that slide presentation you've given us, it's not on our systems. Are you going to distribute that to us?
I sent it to Marie just this morning, so yes.
Very good. Okay. Right. Members, are there any questions? Yes, Councillor Cooper.
Thank you, Mr. Chairman. I've got two, in fact, and I'd like one of them is around the announcement by the government of the rollout of rapid testing, and akin to that, I'd like quickly just to praise you an email that came in this morning, in fact, from a resident, and I'll start. I'm writing today to express my concerns about shopping in Farnborough. During the present COVID restrictions, as I'm over 75 years old, I'm very aware to follow the guidelines issued. I've been very disappointed that lots of people are not sticking to the rules and have been going shopping for more than essential items. I'm not going to go on because I think we've got get the gist of that. So two questions relating to that. I myself have also witnessed around the Rushmore area, people are not taking notice of the rules. Are we liaising with Hampshire Police and asking them to carry out the enforcement in the hotspots around the town centres where there is blatant disregard of the rules going on? Secondly, my second question relates to the rapid testing that was announced by the government over the weekend, and with 1,384 per 100,000 being the rate according to your slide in Rushmore, it strikes me that there is an urgency to get rapid testing established up here as soon as possible.
Many thanks, Councillor Cooper. So if I start with the first one, yes, we are in constant discussion with the police around how we manage enforcement, and also with our district council colleagues. And over the weekend, I was working with particularly Rushmore Borough Council Chief Executive to discuss what we can do and how we further support the need for people to stay at home, and how we increase the number of COVID marshals and ambassador type roles in Rushmore and across the county, because it's only if people follow this behaviour that we will really get to grips with the virus. With regard to the police, yes, they do have the powers to prosecute people, and they do that. It's a last resort measure because it's not an easy measure, but we do that, and we also work with environmental health to work with businesses that are not complying. And one of the communications I'll be doing very shortly is to all our supermarkets to really support them and enable them to really think again about how they're managing social distancing and their supermarket flow. So yes, all of those are in train, and I agree it's really important. With regards to rapid testing, you're absolutely right, that was the announcement made, which is, I learned it at exactly the same time as you did. We are looking at how we can roll that out, developing our plans with colleagues, and you're right to say Rushmore would be an area of focus for us within Hampshire County Council area to see how that could work. Now, as I mentioned earlier on my slide, community testing isn't the answer to everything, because we know that, one, it's not, the lateral flow is a good test, but it's not 100% accurate, so it's a nudge for behaviour. And secondly, we need to think about the logistics of how we set that up. And we know that people, the Liverpool example, we know that actually those people who might perhaps require a test or be the ones who are not following social distancing aren't the ones going for tests. We get there worried well. And what we don't want to do is bring people out of their homes unnecessarily. So we're looking at all of that to see how we can set this programme up, because currently the test isn't licensed to be undertaken in someone's home without a professional there. So all in train, and we're developing those this week.
We need to hear you, Rod, if you're saying anything.
So sorry, I thank you for that, Simon. I can only express my extreme concern about the Rushmore area, as you can appreciate. Some of the supermarkets in the area are very good at carrying out enforcement. Others are absolutely appalling, and it's the appalling ones that are concerning me, and they're the ones I think that we have got to focus our education with, and they happen to be in the centre of Farnborough.
Yeah, absolutely, and I was speaking to colleagues tonight about that.
Thank you. Next question comes from Councillor Jonathan Kenty.
Thank you, Chair, and thank you, Simon, for your presentation. I've just got a couple of questions about Rushmore as well. So firstly, it appears that the infection rates in Rushmore are rising everywhere, but there does appear to be a faster rise in areas where there's generally higher rates of deprivation and density of housing. So thinking particularly of sort of Mayfield, Aldershot Town and North Town. So my question is whether Hampshire has considered targeted health promotion messaging in specific ward areas, perhaps working in partnership with local groups and organisations. And secondly, with the higher positivity rate that we are picking up in Rushmore compared to other districts, is there any patterns that you can observe with that, such as age or occupation?
Yeah, really interesting. So yes, deprivation, we do target our messages as appropriate, particularly thinking about people's who people are, so males, females, ethnicity and those kind of things. So you're absolutely right, it's really important. We need to be really mindful when looking at ward rates, because the ward geography is so small that actually the fluctuations are not that helpful to look at, and we do know, but we are concerned, and we are working, as I said, with colleagues within the Borough District Council and Hampshire County Council to further promote the right messages. I think really it's about how do we encourage our population to take this seriously. We've heard from both many hospitals this morning. It's a really serious position we're in, and we all need to act as if we've got the virus and stay at home and keep that message for our community. Your second question was about how do we, I think it's about targeting. So yes, we will continue to do that with our comms and our insight team that we look at and make sure the messages meet the people's needs.
just to follow up very quickly. So I did ask as well about the fact there's been a higher positivity rate in Rushmore compared to other districts, and whether there's any sort of patterns you can observe about why that may be the case.
We're seeing increased positivity across all age groups, particularly in that older age group from looking at the data. But yeah, across all age groups, no particular patterns there. We look at all the data, look at if there's any specific outbreaks to deal with. So we're managing all those as well. But it's community spread and within households.
Thank you, Simon. Next question is from Councillor Hare. Councillor Pal Hare.
Thank you. Thank you, Chair. Simon, thank you for your presentation. Just a quick question, a clarity on facts and figures. When the death rates are recorded, lots of people are quite confused, and they believe that on the certificate it's all COVID related and not other causes. So can you just give me a little explanation on that, please?
There's a number of ways to record death. And so what I presented here is where COVID is mentioned on the death certificate. However, there are a number of other ways to do it, and that's just for standardisation to make sure that we can look at that. I think that's what you're asking, but there will be other ways and other statistics, and why it's really difficult to compare across countries, because everyone records death slightly differently. But the most sensible way to do it is a factor in the death on the death certificate, which is showing that COVID contributed to that death.
Thank you.
Thank you, Simon. Next question is from Councillor Dowden. Councillor Aaron Dowden.
Yes, thank you. Thank you, Chairman. Following on from Councillor Cooper's concern, over this weekend there's been problems in the past as well, particularly in the area I live in, at the leisure centre. I had numerous emails and a few telephone calls about the numbers congregating on a skate park. Mm-hmm. And also a lot of parents were there watching with them, and they were very close together in large numbers. And there were a lot of people, I don't know whether they travelled from somewhere else, like a scooter club, that was explained to me. And anyway, I tried to ring 101 and then was told to go on the website to report it, a COVID activity, so that the police can respond. Well, to be perfectly honest, you can't expect a member of the public. I waited ages trying to get someone on 101, then tried on the web page, which obviously is the police, and to no avail. It was a total waste of time. And so if I was trying so hard, other people would struggle. Now, I did actually notify Inspector Turner in Test Valley, and of course they do their best, the police, but within Test Valley their numbers are so low, quite frankly. There is no way they can police it properly. They can't be there all the time. So I don't know what the answer is, because people ought to realise the seriousness of this. I mean, a good example is at the Christmas time, there were, Isle of Wight was opened up because it was in tier 1, and now it's in tier 4 in such a short space of time. That can only be as a result, one would have thought, of releasing people to do what they like over the Christmas period, because I don't think we've had the real effects of the Christmas period yet, have we?
So really good questions there, Councillor Dowden. So on the skate park issue, we are working with police on that over the weekend, because you're right, play parks can stay open, but specialist sports sites can't. And there's a bit of confusion, so we're just clarifying that. Now, if they can stay open, you're absolutely right. It's really concerning that people are collecting and meeting with each other when actually the guidance and the advice is you must not. So we're working through that. And again, we do need to make sure that the physical and mental health of our children and young people, I guess those are mainly the skate park users, but obviously everyone, any age can use them, are able to, get out and exercise as per the guidance. But you're right. We need to make sure that people understand the guidance. And again, we'll be working with our colleagues to further have COVID ambassadors and COVID marshals in those areas so that actually people understand what behaviour needs to do. And I think as a group of people and as a population, we all need to think about how we manage that and how we get to the point where it's okay to say, please, can you step away? And with regard to the police, you're right, they don't have a huge amount of resource. They do have resource to manage these things. So if there's an issue that we need to pick up, and I can pick up with police to see what further we can do to make that an easier route. They can't respond to everything, but if you'll give me permission, I'll take that away, Councillor Dowden, and see what I can work with the police on.
Thank you very much.
Thank you, Simon. Next question is from Councillor Julie Butler.
Thank you, Chairman. It sort of kind of leads on from what everybody else has just said, actually. I mean, the skate parks is a really difficult one because most of them are very open. How do you shut them down so people can't go in? And I don't know. My question, though, was more about, is there any way that we can do more communication with the local schools and colleges? Because I know the schools have now closed, other than for children of key workers. But the issue you have is, I think, that the local children who were in their year group bubbles or class bubbles or whatever they were in still think that it's quite acceptable still to carry on in their groups of 8, 9 or whatever, 10 in open spaces, because that's what they're used to doing. And you know, it goes back to the transmission rates that you were talking about. They're taking it home and it's not going to actually solve any problems. So I think the more we could do perhaps with communication with the schools and the colleges, just so that it gets it through to them that they shouldn't be actually sitting around a table in a park of about 8 of them chatting when everybody else is trying to socially distance, would be probably quite helpful.
You're right, Councillor Butler, and we're working really closely with the schools, communicating with them on an extremely regular basis about how to manage things in schools, and also how to manage the testing, which is announced at the end of term, and also how to manage things out of school. And we were doing that all the way through last term when schools were more fully open. And I know my colleague, head of children's services, you know, they are still open. And how do we really help schools to understand that? And you have to also appreciate it was at this time last week schools were open and they closed overnight. So it is a changing feast, and we are working with the schools to make sure they can promote those messages, because you're absolutely right. It is needed. The school gate, where particularly around infant schools, parents collect and meet their children. So it's complicated. Schools doing a brilliant job, and we are doing more we can to support them, but we'll make sure those messages feed in.
Thank you, Simon. Last question is from Councillor Tonya Craig. Councillor Craig.
Thank you, Roger. I wasn't going to mention this here, but I will because it's come up, about the social distancing around areas. I've been sent a couple of photographs this morning of outside a vaccine hub in my area, where there are lots of people, no social distancing, no masks on, you know, and this is a path that is used from a housing estate to a little shopping centre as well. And it's caused a real issue. Lots of people making comments about it. But the interesting thing is some of those waiting for the vaccines were healthcare professionals that have got their masks in their hands whilst they're stood all very close, laughing, joking, chatting away. What can we do to stop that? Because it's a real issue. You know, people are saying it's all right for them, they're getting vaccinated, but what about us picking up their germs afterwards? Thank you.
You're right, it's a real issue, and actually the vaccine isn't the answer yet. We know it takes a little bit of time to provide an immune response, and as Jenny Irwin said earlier, we are taking a different approach. We're trying to give everyone the first dose so they won't have full immunity, so some people may still catch it. We have worked really closely with our NHS colleagues, because what we found is, you know, they're working really hard on the wards, wearing PPE, social distancing. As soon as they have a break and have a cup of coffee, it kind of gets forgotten. And I think that's the same for some other professions. So we're working very closely with the NHS and others to say you need to manage social distancing in all settings. And it is really hard. I realise that, because actually after you've had a really hard shift or a hard lesson or a day's teaching, you want to connect with your colleague and just go, oh, that was hard, or I'm tired. And we're not able to do that. So we are continuing promoting those messages, and the comms going out over Christmas from Hampshire County Council really was pushing that we need to manage social distancing and safe conduct.
Yeah, thank you for that, Simon. I really do appreciate all that the health professions are doing, but it just seems that, you know, they're doing what they can to promote the social distancing, and when you see those kinds of get-togethers where there isn't the social distancing, people think that they're being told to do something just because they are, rather than the risks. So those disbelievers, if you like, you know, they see this and say, well, if the healthcare professionals are doing it right outside, it's not as big a risk as we're being told. So it's just, you know, it sort of goes against what we're actually telling people.
It does, and we'll continue to put that in the messaging.
Thank you, Simon, for your presentation and contribution as ever. I did see you on television last night and it came over very well, so that is good. The message does seem to fall on poor ground in some places, which is obviously a great weakness in our battle against this virus. Chris Whitty is more or less saying the philosophy should be, let's all assume we've got the virus and therefore we're potential vectors. So let's take appropriate action, keep our distance, etc., etc. Why that message is not universally accepted, I don't know. Because if it were, we could snuff this out very quickly. Anyway, we are where we are and we must battle on. So thank you for that. Can we note the director's report on this, please, as an update to the COVID situation as far as public health is concerned?
Agreed.
Noted.
Thank you. Now we go on to item 8, which is the Adult Health and Care COVID update. We've got both the director, Graham Allen, and we've also got Assistant Director Jess Hutchison. You're both there, I'm sure. I don't know which one of you is going to speak first, but over to one of you.
Thank you, Chairman. Good morning, or rather, sorry, good afternoon, members. It's Graham Allen. I'm going to put the presentation up and then hand over to my colleague Jess to take us through the first half. I will then come back in and give an update in terms of the care home sector, but also making comments in terms of the wider social care sector across Hampshire. So hopefully you will now see the presentation just loading up. Good. So Jess, over to you.
Thank you, Graham. So this is a brief resume of our work on response and recovery, and Graham will go on to talk about the care home situation. If we could just move on. So I will start to speak while the slides load. So you may recall, it feels like a long time ago now, but in November, Adults Health and Care on the 4th of November moved to our emergency response mode, back out of recovery. And we continue to focus very hard in terms of operationally directing in a number of areas, including hospital flow, disruption to buildings and staff, our support for carers, which is of course crucial at this time because a number of carers are at home supporting their sons or daughters or partners with disabilities. Commissioning, so our support around outbreaks, working closely with public health, our support to the market, the social care market generally. Directly provided services through our many nursing homes and care homes that Hampshire County Council run ourselves, and also focusing of course on the welfare response, which is our response around bringing basic to support to a much wider frail community and people who are clinically extremely vulnerable. So it's important to say through the first lockdown and indeed moving on to the second and ultimately this lockdown period now, we continue to monitor against our Care Act responsibilities. And one of my roles within the department is as principal social worker, so making sure that we're absolutely doing all we can to manage the risks associated with our COVID response, to make sure that we're still providing an adequate service to people with disability and older adults in Hampshire. So I'm aware that unfortunately that I don't think the slide pack is moving on, so I will just continue because we're short for time, if that's all right with you. So what we know also is that we have a clinically extremely vulnerable cohort of people in Hampshire, circa 53,000 people who need support, and we have been approaching them. In November, we went back to that group of people to check they were okay because of that period of lockdown. We've obviously moved through in December to significant tranches of Hampshire becoming tier 4 and moving again into arrangements where shielded guidance needs to be enacted, which is basically saying to a wide group of people in Hampshire, you need to stay in, you need not to use pharmacies and shops. Obviously, it's up to that person's individual discretion, but the health advice is for them to stay away from those kind of environments. So we've been providing volunteer support and proactively approaching large numbers of that group of staff, group of community to people to support them at this time. So thinking then, as you already heard, the statistics around our clinically vulnerable and the people that we phone change all the time. We've now approached 93,000 people in order to support them. Of that group, we're providing between 15 and 30 referrals through to our district and voluntary community colleagues every day. And those volunteers are then providing food and also providing prescription delivery where appropriate. So fantastic work still going on with our districts and with the VCS. And unlike other areas of the country, we haven't got that kind of issue around capacity at the moment that we're seeing in other areas around our volunteers. We've still got ample volunteers doing their job stoically. So thank you very much for that. Just wanting to say a little bit more about day services. So in our day services, unfortunately, as we've entered into this new period of lockdown, we decided to restrict and reduce opportunities around day services further, although also at the same time making sure that those people who are at risk, and because of a risk of family breakdown, for example, and carer strain, still receive one-to-one outreach and those types of things. The issue has been, of course, that in shared environments, in day services where people are grouped together, this does not work well, particularly when people are at risk of infection and have other disabilities. For example, people with learning disabilities are at high risk due to COVID, as are some older adults. So had to restrict the use of day services, but making sure where needed, alternatives are in place and that we continue to stay in touch with those individuals and support them as much as we can. So one of the things I'm pleased that Simon has talked to you about today is the further rollout of testing. We are looking at that in our day services situations really hard to chime in with the national response around lateral flow testing. So hopefully we'll be able to move forward as infection rates decrease to recover our day services in good time. And I'll hand over to Graham to talk more about care homes.
Thank you, Jess, and my apologies. The presentation is showing through on my end, but clearly not on yours. So members, please forgive me. It's probably an operator error. If I can
quick interrupt. The presentation is coming through. It is lagging, but also members do have the ability to look at the presentation on their iPads. So as long as you announce the title of the slide we're supposed to be looking at a given time, we should be able to follow you quite well.
Of course, thank you, Chairman and members. I've got literally a handful of slides. So I just want to talk to the first of my substantive slides that is headed Visiting Guidance, issued the 5th of January by Department of Health and Social Care. It's important to note that particularly in care home settings, there are further revisions to care home visiting. We had seen very positively, and Hampshire was one of 3 local authority areas to participate through November and into mid-December in lateral flow testing for care home visitors, on the basis that that was a pilot subsequently rolled out across care home settings nationally. But what we've now got issued as of last week is that whilst people can still visit care homes to see loved ones, it's really returning to what we saw earlier last year, in that those visits must be taking place with substantial screens between the care home resident and their visitor, or using visiting pods, which would be a whole variety of specific buildings and spaces that can be COVID secure to enable visits, or indeed through and between windows. Very, very importantly, close contact, which is what the lateral flow test pilot for visitors was seeking to enable visitors, although wearing PPE, to be able to hold the hand of a loved one and to have that closer contact. That is not permitted. So we should not be seeing visits within care home settings taking place at the moment. There are, of course, as you've heard throughout the course of this morning, exceptions to every rule. And what we are supporting and what we're seeing across care home settings is a very sensible and pragmatic approach to enable, for example, visits to take place in an appropriate way where a care home resident may be at an end of life phase. So really the comment that was made earlier by Andrew Bishop around visiting in hospital settings at end of life care, it will depend on the circumstances and the care home's ability to safely enable such a visit in those circumstances. We're also seeing that there's separate guidance for people in supported living environments, and supported living in this context is a bit of a shorthand for a whole variety of different accommodation settings, which range from extra care housing to supported living through to shared lives and indeed some sheltered accommodation types. So it's important that providers are making reference to that guidance, and certainly through the work that we're doing, we're making sure that the whole of the wider sector is currently and constantly being updated with changes that are being made to such guidance. Again, in line with comments already made, the picture is extremely dynamic, both in terms of what's happening across our communities and in care settings, but also in terms of revisions and updates to guidance. So we are on a constant basis communicating with providers. We are on a constant basis through member briefings and indeed wider communications, seeking to bring all of our communities with us as we go forward. I'll now move on to a slide which is a screenshot from the dashboard that we've been using for some 8 months now. It's called the Care Sector Dashboard, and you'll see that there's a variety of little diagrams and maps. You may not be easily able to see the detail within that slide, so I just want to pick out a couple of key elements. And of course, since this slide was put into the presentation from last Tuesday, that's the 5th, there have been further updates and revisions to the detail included on this slide before you. So just to remind you, we've referred to this previously in updates. There are some 472 care homes across the county of Hampshire. So that is the county of Hampshire, excluding the 2 cities and the island. Within that, we've got currently around about 62 of those care home settings with an outbreak of COVID-19, and an outbreak is defined as 2 or more cases. So the threshold for declaration of an outbreak is relatively low, but I know all members will appreciate that it needs to be relatively low in terms of ensuring that we don't see COVID taking off in any particular care home setting, which is what we had in the early spring and early summer of last year, the consequence of which is well known, and I won't rehearse here. So across those 62 care home outbreaks, we've got a grand total of just under 300 people currently COVID positive or suspected. And that number, I have to say, has largely remained constant over the second half of the 2020 calendar year. So once we saw the initial peak within care home settings in the spring and early summer of last year, as we started to move through the lockdown, and lockdown started to be eased through August and into September, we certainly saw that rate decreasing with care home settings. It's been at the constant level really of around about 60 or so outbreaks at any one time. But I want to reinforce that those outbreaks that we've seen and those outbreaks that we have at this moment in time are of a much lower order in terms of care home settings from anything that we saw in the spring and summer of last year. And again, members, a line I've used previously, I'm going to use it again because it's really, really important because of the absolutely phenomenal work that has been undertaken across care home settings by providers in residential and nursing care settings, supported by colleagues from the NHS and the local authority in terms of infection and prevention measures that have been undertaken. The other thing I just wanted to particularly point out from this slide, and again it was picked up or picking up a comment that was made by Dan Bradbury earlier from Frimley in terms of flu vaccinations. You'll see in around the middle section on the right hand side of the slide before you that flu vaccination for residents in care homes was just under 80%. Now that as a rate of flu vaccination is at a level higher than we've seen in previous years, and again that's really positive, and that's testimony to the work that's been done across the whole sector, working with GP partners across Hampshire to make sure that residents are vaccinated in terms of seasonal flu. Probably in terms of this morning's presentation, the more important thing to say is that we've now started from care home provider reporting to pick up the number of COVID vaccinations that are being provided to residents in care home settings. The numbers that we're receiving are coming through from providers who are self-reporting 2 to 3 times a week through the National Care Tracker. So these figures will not be precise. The actual numbers will be higher. But as of last Tuesday, we saw around about 12%, and that was around about 1,300 residents in care home settings that had a COVID first vaccination. Very positively, I can say that between last Tuesday and close of play last night, Sunday the 10th, a further 8%. So we're now up to 20% of all care home residents. And again, just to make the point, there are almost 11,000 care home residents currently occupying care home beds across Hampshire at the moment. And I can also positively say that 23% of staff in care home settings, you remember from the earlier presentation from Jenny Irwin, that social care staff working in care home environments are also a key priority group for many obvious reasons. So we're seeing the number of residents and the number of care staff in care home settings tracking each other quite closely. The important point to make is this is before generally the Oxford AstraZeneca vaccination has generally been rolled out and made available. We're starting to see deliveries coming through from the tail end of last week, but one would hope, subject to those supplies being delivered, again in line with comments made by my colleague Jenny Irwin earlier, we will over the coming days and weeks see the numbers of COVID vaccinations for those in care home settings and staff increasing, hopefully in a very marked way. I'll now move us on, please, if I can, to the next slide. which is progress of COVID within Hampshire's care homes. The numbers that you'll see there are really updated from what we've previously presented. I've just included in the top line there the snapshot between the 24th of October and Christmas Day. What it clearly outlines is a further 555 deaths. I've put in the brackets below that the period before, and the period before is really from the start of COVID outbreaks in Hampshire and particularly in care homes, so the 28th of February. So from the period, the 28th of February through to Christmas Day, there have been a grand total of 3,867 deaths within care home settings. Of that number, around about 512 now in total have had COVID identified on the death certificate. And again, in line with comments made by Simon Bryan earlier, there are many ways in which a death may be recorded, but we are keeping close track where COVID is either the cause or a potential contributory factor on a death certificate. And in, as I say, 512 cases, COVID has been recorded on a death certificate, either as the cause or something present at the point at which somebody died. And of course, our hearts go out to all of those people and all of those families. It's been hugely traumatic for all involved, including staff working in those care home settings. There is a huge amount of fatigue, but also a huge amount of resilience. And indeed, day in, day out, the work that's being undertaken is nothing short of breathtaking in terms of supporting our most vulnerable residents in care home settings. I'll then move on to my final slide, which is continued vigilance and support. Hopefully the slide will move on. There we go. And this is really just to pick up on some comments and points which I think are important to know. Some of them have been built upon or mentioned already through the course of others' presentations this morning. The first comment I want to make, though, is with regard to risk and failure across the sector. We know the consequence for the sector and for individuals has been significant and fundamental. There's something different at this moment in time, and it's not to say that it won't return to a pattern that we saw in the spring and early summer of last year, but at this moment in time, the characteristics of the current increase in COVID is slightly different. We are seeing far higher numbers of people in hospital settings with COVID, and to some degree that was on the basis that hospitals, in anticipation of surge last spring, created a huge amount of capacity. So a huge number of people in acute settings were discharged out into the community and out into care home settings. And from there, in advance of routine hospital tests for COVID last spring, we saw a very significant upsurge in cases across care homes environments. At this moment in time, we're not seeing that. We're seeing the pressure, as I say, in hospitals, and you've been given lots of facts and figures from my NHS colleagues this morning in terms of the presence of COVID positive patients across our acute hospital footprints. The other thing that's slightly different this time round, given the presence of COVID in all our communities, is we're starting to see greater consequences and impacts in domiciliary care. So those care providers that are going into individuals' private homes, we're starting to see, and we've been seeing it now for several weeks, to be fair, an increasing number of domiciliary care workers needing to self-isolate as a result of testing positive for COVID themselves. And that's an indication of the general high levels of COVID in all of our communities and all settings. Care homes, we haven't, as I say, started to see a massive upsurge at this moment in time. Fingers and everything else crossed that we don't. We're also seeing generally through national lockdown being applied, increased risk to individuals and families, not only with regard to younger working age adults with learning disabilities and complex support needs who live at home with family members, but we are particularly concerned about the risks to those younger adults, as I say, with complex disabilities, given the need to suspend a whole range of usual activity. It's not to say they're not being supported by a variety of outreach, but things like day opportunities are not currently taking place for a large number of younger adults. Positively, members, we have as a local authority been able to ensure that government grant funding around infection prevention control measures to the care sector have all been very positively distributed. So you'll see on the slide more than 30 million in terms of government grant funding. And in addition to that, Hampshire County Council funding and indeed NHS CCG funding earlier in this financial year that's gone out to the sector. My concern is, as we go forward, that we've distributed all of the grant funding that government have thus far announced. Care home providers and social care providers are clearly starting to say that they will quickly have spent all of that grant funding and are keen to know whether further grant funding will be made available. And at this moment in time, we don't yet know. And finally, as I've said, the vaccination programme is rolling forward very positively. It's hugely complex. We need clearly to follow the priority groups as set out by government, in line with the way in which vaccinations should be undertaken by those primary care networks and those vaccination centres. It is a massive logistical challenge. There is no two ways about it. Positive progress at this moment is being made. We, as a local authority, are working closely with NHS partners. NHS partners, through the national programme, are leading. We are seeking to advise through that programme, through having subject matter experts in terms of the care sector, and also seeking, it's a question that was asked earlier in terms of the voluntary community sector. We're also seeking to make sure that there is clarity for all sections beyond those currently within that programme, without getting in the way of our NHS partners in delivering at speed the vaccination programme. So thank you. I will stop there, and if the presentation can be taken down, I'd be really grateful. Thank you.
Thank you, Graham, and thank you, Jess, for that update. Thank you both for the way in which you conduct the choreography, if you like, of your staff and all the social workers, and the way that you've been interacting with all the care homes and the NHS. Very valuable work and very much appreciated. Thank you. I've got 4 questions, and I'm only going to take 4 questions. Councillor Dowden, please.
Yes, thank you, Chairman. First of all, Graham, once again, I'd like to thank you and all your staff for the work that you do. But can I just ask you something about the figures you gave there, for example, with the COVID deaths and whatever? You had a figure up there, without it in front of me, it was 3,380 or something or other from February to October. And then you had a further 550 something or other, so almost 4,000 deaths, if you like, in a 12-month period. How would that, because it's very difficult actually for GPs or anybody for that matter in the stress they have to be able to definitely say it was COVID or whatever, because people could have died of something else. Can I ask you, what is the comparison from previous years, if you like, and that way we could get a good indication how the impact COVID has had, really? In other words, was it the year before 2,500 deaths and then whatever?
Yeah, it's a really important question, but it's also really difficult to portray easily an answer to that. So if I give the answer in the following way. So the period between the 28th of February and the beginning of October last year, so that's that figure of 3,312 deaths. Within that, there were approximately 800 excess deaths. So we would have anticipated in a usual year to have seen around about 2,500 deaths. in that same period up until that point, and it was some 800 deaths higher, and that's based on a 5-year average. So, you know, there's fluctuation from any one year to the next, which is why the 5-year average is the best barometer of what we would expect to see. In the period since then, so in that period from October up until Christmas Day, there have actually been 80 fewer deaths than we've seen in the 5-year rolling period. So my response would be the number is significantly higher thus far this year, but it's in the first half of this year, financial year, and we won't know until we get past April and we can look back to have any degree of confidence in terms of what's the financial year 2020-21 look like in total number of deaths in comparison to that 5-year average, and then also diving down into the detail in terms of the numbers of deaths are a consequence of COVID. Either directly somebody died because of COVID, or they died of other causes but COVID was present. And of course, you're absolutely right in the question that you ask. It's notoriously difficult to give a simple answer. Did an individual die of COVID and only COVID, or was COVID present and it led to a whole range of other factors, including underlying health conditions, which caused somebody to die sooner than otherwise they would have done? It's very complicated, and I'm not necessarily got that specialist knowledge to give an easy answer at this moment. We will need to look back with a little bit of hindsight.
Thank you, Graham. Thank you, Chairman.
Thank you, Graham. Next question is from Councillor Harrison. Councillor David Harrison.
Thank you, Chairman. It's a quick question. A national inquiry. I appreciate at the moment we're still in crisis mode. There will be things that went well and things that went less well. Will you be participating in a national inquiry, and when are you expecting it to be?
So the simple answer to the first part is, assuming a national inquiry is called, yes, absolutely we will. And just to add a little bit of detail, and I've said this to members previously, we are undertaking a learning review with regard to our own direct care provision. So HCC Care, which is our establishment of care home and other direct provision that Hampshire County Council directly provides. Of course, as we go forward, we're needing to make sure that we're not doing something historic based on what happened in the spring and then disregarding what's happened subsequently. So we continue to roll forward in terms of that learning review. And of course, we are ensuring that we're embedding learning at every single possible opportunity. But also in my role of chair of the Hampshire Safeguarding Adults Board, working with a huge range of partners, not only in the social care arena, but across the NHS, the voluntary community sector, housing, and so on across a whole range of different services. We will also, in due course, be publishing a learning review in terms of what went well, but also, and really importantly, what hasn't gone so well in terms of individual or multi-agency approach to COVID. Again, given the fact that we're now back into a national lockdown and we are back into full response, there is still a little bit of further delay before we will get there. In terms of a national inquiry, to the best of my knowledge, that hasn't yet been announced. But certainly, as and when one is called, we will absolutely participate to the fullest of our ability.
Thank you, Graham. Next question is from Councillor Carpenter. Councillor Fran Carpenter.
Thank you, Chairman. Yes, Graham, thank you very much. A huge amount of money has been given to infection prevention in homes. Millions across the country, but Hampshire has given good lump sums to care homes specifically for that prevention. But I am aware of care homes. At the moment, there is one I know of that has got 7 staff with COVID. They've actually had tested positive for COVID. I also know personally know domiciliary staff who haven't been given, this is not actually in Hampshire, but they haven't been given real guidance or really strict rules about travelling from home to home. They have had some, but not much, and I don't believe they've had what they need to really do what they should. It's very difficult. The whole thing is very difficult, but I just wonder what extra advice are we giving our homes and support staff, and are they actually doing what they're asked to do, all of them?
Yeah, thank you, Councillor Carpenter. What I would say is we are working very closely on a constant basis with my colleague Simon Bryant, his local public health team, but also with the Public Health England health protection team, with NHS partners, to ensure that there's an awful lot of support beyond the money going into the care home sector. And indeed, there is an absolute wealth of information and advice which is made available on a very regular basis to the sector. We're holding regular webinars in terms of making sure that care home providers and their staff are able to take advantage of all of the most up-to-date information, advice and infection control measures. We've also worked really hard, and will continue to work really hard with not only the domiciliary care sector, but the whole of the social care extended sector within the community. In terms of your question, can I guarantee, or could I say that all providers are doing absolutely everything that they should do all of the time, and all of their individual staff? I think it would be rather foolish of me to say yes, of course they are, because we absolutely know they're not, and that will be based on a whole variety of individual idiosyncrasies. And indeed, Councillor Craig raised the issue earlier in terms of staff waiting at a vaccination centre to get a vaccination, not following social distancing rules, wearing face coverings and so on and so forth. None of us are immune in terms of not doing the right thing some of the time. We continue to reinforce those messages. We continue to work in support of everybody within the sector, and more generally across communities, to continue to always do the right thing. But it's both a positive thing. We're all human. We have free choice. The flip side to being human and having free choice is sometimes you don't choose to do the right thing, and we're certainly seeing that in care settings from time to time. Your question, or rather your comment about 7 staff in a care home setting, I think we're probably talking about or thinking about the same one. We have some real concerns. We are putting in additional capacity to support that care home. It's what we've been doing throughout. We will continue to ensure that care homes are both supported, but also where we need to, we will take decisive action. And if we are concerned that a care home is likely to fail, we will take action sooner rather than later, because actually in the period between a decision being taken that it could fail and it failing, risk may be increased both to residents and also to staff. So there is something here in terms of always seeking to be on the front foot.
Thank you, Graham. Last question from Councillor Adam Carew.
Thank you, Chairman. Well, I won't repeat what Councillor Carpenter's asked, because she's asked most of the question I had. However, what plans do we have to test our care workers and also those who are subcontractors that we use? And I'm not thinking so much of the homes, but in particular where we have multiple clients that a care worker may see in one day, who are basically either bed-bound or at least home-bound. And the other question actually is, do we have anyone who's checking up on these care workers and subcontractors? And for example, have we thought about putting up like a plastic sticker on doors, which will, basically say, wash hands, wear mask, etc., social distance? It sounds very basic, but sometimes you need to put it in front of people's faces.
Yeah, and if I can invite Jess to respond to that. Thank you, Jess.
Of course, I think one thing to mention actually is the wealth of commissioning information for the market that we have online, and the kind of very colourful and I think excellent actual communication strategies around webinars and other things to really provide guidance for staff when they don't know what to do. And certainly we've had some very positive feedback from some providers who found that very helpful, and they said that we are communicating a lot with them as a local authority. With regard to vaccinating our staff and the market, plans are in development as we speak. So we've had a number of meetings over the last couple of weeks to really look at the cohorts of staff that we have that aren't in care homes that we would want to have priority access to vaccination. And we're working with public health, with our CCG partners and across the council to think about not only that list that we're looking at for priorities in social care, but then what we move on to later, but actually that real priority right now to say, who of our commission services do we really need to make sure are on the list, and how can we help enable and facilitate that for, you know, with the NHS and with that public health advice.
Thank you. And just to add to that, so we have seen, and some of this was borne out by the initial learning undertaken nationally in the spring and summer of last year now, in terms of the impact on the care sector. So we have seen the rollout, and it's now twice weekly testing for staff in care home settings and monthly testing of residents. That was based on the advice and the insight that came through from that first surge that we saw in the spring and summer of last year. As I said during the course of my presentation, we are seeing the characteristics currently being slightly different. So greater presence of COVID in acute hospital settings and also in community settings. My colleague Simon Bryant made reference to the fact that lateral flow testing will be rolled out across every local authority area for all kinds of different sectors and workforce. One of the key opportunities is in terms of that domiciliary care workforce, who up until this point have been seen as separate and different from the care home workforce. And we are very, very mindful that individual domiciliary care workers have needed to be tested in line with other people in the community, rather than through regularised lateral flow or indeed other testing by virtue of being a domiciliary care worker. So to some degree, that is the process that is now being put in place based on the new variant and the transmission rates that we're seeing across the community. And as I said, we are seeing greater numbers of domiciliary care workers having to self-isolate, and actually that as a sector is under greater stress than indeed generally, and it is a general point, the care home sector. It's not to say that every sector of the wider social care sector is suffering from fatigue, given the length at which all organisations are responding now to COVID.
If I may just come back, a response to Jess, and that is, I think webinars are all very well and have their place, but it's ensuring it cascades down to the individual workers on the ground, some who may not even have English as a first language. Thank you.
Yeah, point well made. And again, just in terms of that detail, so we do have quality teams, again, working hand in hand with NHS partners. We are very active in this space in terms of clearly COVID has had an impact on the ability of the CQC to be carrying out visits. And one of the things that we've been wanting to avoid is to see CQC inspectors going into a whole variety of different services because of potential risk that could cause. So therefore, our attention has absolutely been focused upon making sure that agencies, providers of all kinds, are absolutely adhering to the appropriate infection prevention control measures practically. And where we have concerns, or indeed hear that they may not be, we are taking action.
Excellent.
Thank you, Graham and Jess, for your input to this item. Very much appreciated. we come now to the recommendation. I'm inviting members to note your updates. Members, are you happy to note the updates?
Happy to, Chairman.
Happy. That's good.
Happy.
Thank you. Thank you. And once again, Graham and Jessica, many, many thanks for all that you're doing. Keep your strength up and keep going. Thank you. Right, we can now move on to item 9, proposals to vary services. There are 2 that we need to consider. The first is Southern Health's NHS Foundation Trust proposal on the Beckton Centre closure, and then after that there will be the Southern Health report on the out of beds update. So can we take the Beckton Centre closure first? Is Adam Domine there?
I'm here, Chair. Ron Shields.
I can only just hear you, Adam. Are you on a microphone system? Can you hear me?
Chair, I'm Ron Shields.
I can hardly hear you. Is that the case for other members? Can you hear?
No, I can't hear.
No, we can't hear them.
Perhaps you need to shout up, Adam. Get very close to the microphone.
Chair, I don't know whether you can hear. Ron Shields?
Yes, I can hear you, Ron.
Right. I'm here for this item, Chair.
Ah, right. But both items?
Yes, Chair.
Right, okay. Go ahead then, please, Ron. You're very welcome. And I'm sorry that it's taken quite so long to get to this point in the agenda.
Thank you, Chair, and good afternoon. I mean, clearly the discussion about COVID has to take precedence, and there's been a very good discussion on that. The Beckton Centre, the facilities have not been fit for purpose for quite some years now, and the site has been minimally used. For the services that we do have there, we found what we think are local solutions, and we've agreed those solutions with all of the teams who work on the site. So it's a non-contentious issue with the support of those services. I'm happy to answer any questions, but would hope to look for the support of the committee.
Thank you, Ron, very much. Got one question from Councillor Carew.
Apologies, Chairman. I don't know what's going on with my sound thing today. It's not working properly.
You had a legacy, I think we call them legacy hands. It was there from the last question. Okay, any question? Yes, there's a question from Councillor David Keys. David.
Thank you, Chairman. Yes, how did it get to the state of being unfit for purpose in the first place, please?
It's been over a number of years. The Trust actually took it on in 2001 from the Salisbury Trust, so it was not in great condition at that stage. But essentially, we would need to spend something in the order of £250,000, £300,000 to upgrade the fire precautions and to do other work. So it's a 1950s building, which essentially we've outgrown the purpose, essentially. But we have some very good facilities where we're looking at the alternatives.
Is that okay, David?
Yes, I mean, it sounds to me as though there's been a lack of investment on the site. I mean, that's what I was getting at. I think that's what it sounds like, anyway.
It's a 1950s building. I mean, essentially, in terms of care, we have at the same time developed other services. So, for example, Lymington Hospital, is a fabulous facility, has been developed in the intervening period. It's an old building. There's now better places to provide those services, and it would be difficult to justify spending £250,000 essentially on that building.
Okay.
I think the important thing is we are where we are now. The services that it provides have been distributed to other places and are all happening. So I think it's a pretty obvious thing that as a committee, I'm sure we can support the recommendation of the planned closure of Beckton Centre. Is that agreed?
Agreed.
Councillor Andrews, you wish to say something?
Thank you, Chairman. Reading the papers, it seems like a no-brainer, to be quite honest.
Yes.
The way everything has been changed around, and using Lymington Hospital and using the nursery site, I think it looks like it's going to be better in the future for all of the people who use this centre. So I'm greatly in favour. Thank you.
Thank you, Councillor Andrews. Councillor Carpenter.
Thank you. Yeah, it's actually very close to where I live. I just want to say that the work that the Beckton Centre has done in the past has been phenomenal, and people are very sad to lose it. But we have Lymington, so I can see the arguments for. Thank you very much.
In other words, the good work is continuing, but it's relocated.
Yes.
Good. So are we all in agreement that we are happy? Well, not happy, but we support the closure of the Beckton Centre. Good. No dissent. Thank you very much indeed. Ron, would you like to carry on then with the next bit, which is your update on the out-of-bed? Oh, sorry. Who's speaking?
Nick Grandforth with the existing proxy.
Yeah, be good. Thank you.
Okay, so
Sorry, I don't see who's speaking. Anyone wish to speak?
I think it was Councillor Dowden, isn't it? He's unmuted.
No, it wasn't me.
No. Last call for anyone who wanted to say something before we move on to the out-of-area beds update. No response. So, Ron, would you like to carry on with your update for the out-of-area beds?
Thank you, Chair. This was discussed quite extensively at the previous meeting. I mean, essentially, the good news is that we continue to avoid sending patients out of county, out of our services, and we've been able to not have the out-of-area placements, as we call them. The good news beyond that, of course, is that we are building capacity in county, and that's described in the paper, Chair, but essentially creating 10 intensive care beds for women, and that will be at the Antelope Centre in Southampton. We'll also be creating a women's wards at the Parklands in Basingstoke, and that will be another 18 beds. So we're creating the capacity to avoid having to send people out of county, send people out of service. It's not good to send people for their care elsewhere when it's a local service that they need. And we're developing that capacity to be self-sufficient, Chair.
Thank you, Ron. Any questions? No questions coming up. I think you're to be congratulated on keeping your out-of-area beds needs to a minimum. And we wish you the best in opening the PICU at Antelope House and the 18-bed ward in Parklands Hospital this summer. Okay, so we're all agreed that that recommendation can go ahead? Good.
Thank you, Chair.
Thank you, Ron. Sorry, you've been kept rather longer than we'd hoped, but it's good to see the smiling face. Thank you. Right, we can now go to item 10. Is that possible, Marie? Are we go for item 10?
We have Mark Rowell from SCAS on the call, but I think he's been waiting. Let me see if I can call him in. Mark Rowell, are you present? He's showing us on the call, but on hold.
Right. He is one of our operational people, and we mustn't demand that he is with us. This item was specially requested, but I don't think that we would find it difficult to defer this perhaps to the next meeting unless he emerges now and says, I'm here, I can go. I don't think that's the case. And as we all know, the ambulance services are, and the NHS 111 service it is the first response to all sorts of bad things happening out in the field. So I think what we'll do, we'll move on to item 11. Marie, can you keep an eye out in case? You've just
trying
sent
to send him a message to see if he'll pick that up, but if you want to move on, and we might need to defer it to the next meeting.
Yes. Okay. Can we therefore jump ahead to item 11? Now, just to remind our co-opted members, this is all about. Oh, there's a dog barking somewhere. Very good. Right. Just to remind our co-opted members, these items on Hampshire budgets, either revenue or capital, you're very welcome to listen, and I'm very happy that if you wish to, you can ask a question. But when it comes to the end of each of those items and the recommendations, I'm afraid you won't be allowed to vote. So, item 11 then, the adult health and care revenue budget for adult social care and public health. Now, Graham, are you going to present this along with Simon? And is Dave Curden in attendance for the
Yes.
technical fiscal questions?
Yeah, the vast majority of the presentation will be Dave Curden talking to the slides, and then Chairman, you'll hear from both myself and Simon Bryant for a grand total of 3 slides. But just before I hand over to Dave, I just wanted to make the briefest of introductory comments. So members, this is a presentation which will be familiar to you in terms of the format. We tend to, across all of the County Council departments, follow this format each year in terms of presenting the future financial year's revenue and capital budget. What I wanted to say before I do hand over to Dave is clearly the context in which we as a local authority are operating in common with all local authorities has been somewhat changed as a result of COVID and continues to be changed as a consequence of COVID. Having said that, I'm also delighted to say that within the revenue budget that is going to be presented to you through the course of the coming slides, there are no new or additional savings beyond those that have previously been considered in previous years by this committee in response to what was the transformation to 2021 programme. So the budget setting of 2 years ago identified and included changes and savings that needed to be made as a consequence of the medium-term financial strategy. There are no new savings included within the revenue budget proposals before you this morning. I'll pause there and hand over to Dave Curden.
Good morning. Good afternoon even. Just to make you aware, I'm just looking at my notes on the other screen. So whilst I've got my camera on, you can see me. I'm just looking to the right. It's just because I'm reading my notes. Okay.
Absolutely, David. Welcome. And you're obviously the best person to lead us through this minefield of figures.
I'm hoping there's not going to be too many figures, to be honest. Right. As Graham's already presented, as stated, sorry, this is an annual report that we present every year, and this is very much following on from those reports that you'll have seen previously. This briefing is particularly about the year 21-22, and it covers both the adults health and care, that's adult social care and public health, revenue budgets, and the capital budget for adult social care. Can I just check with everybody? As I'm flipping through the slides, they are proceeding onwards, aren't they? And that's what you're seeing.
We're seeing your first slide of presentation outline, David. Thank you.
Thank you. So just to give you some context of the format of the presentation will take, firstly, I'll open up with the County Council context, an update on the local government finance settlement, an update on the reserves position, as well as an update on the transformation to T21 programme. Graham will then carry on from there in respect of specifically for adults health and care T21, and then Simon and Graham will go through the key departmental challenges, and then you'll be back with me for the numbers part of the presentation. So in respect of the County Council context, the first slide you can see is basically showing that we, as a County Council, will have achieved, or we're aiming to have achieved, by T21, £560 million worth of savings. If you put the 80 million that's planned for savings programme 23 into place, that would be £640 million of savings since 2008. At the moment, obviously, you can see there's good progress with T17, everything up to T17 completed. For transformation to 2019, there are a few marginal areas within the social care departments which are still outstanding, and obviously much of the transformation to T21 work streams are still ongoing for the year 21-22. So before we get into looking at the actual budget, before the budget, the scene setting, as it were, what we originally assumed within the medium-term financial statement position. Excuse me. As Graham's already said, and I'll reiterate, there are no new savings as part of this budget round. As highlighted, there are and continue to be delays in savings within the various departments, particularly within the social care department, but that sufficient resources have been identified corporately to meet those delays. Within the MTFS, prior obviously to this settlement, it had been assumed that there would be a 2% adult social care precept, which along with the 2% referendum limit meant that local authorities could increase their council tax by no more than 4% before needing a referendum. And that's our starting position with which to build the budget. Brief update or a brief reiteration of the position in respect to COVID-19. This is as at November, and an update will be going to Cabinet in February, where it's expected that the position, I'm going to choose my words carefully here, is likely to be less bad rather than good in any way at all. So the council is obviously losing income from business rates, council tax, fees and charges, and is also incurring a greater level of spend on various things. Within adult social care particularly, this has been on PPE costs and the enhanced payments to providers to ensure that they are sufficiently remunerated and are there to provide the support that we need for the clients that are discharged from hospital. What I would say is there is much significant other spend within adults health and care, but this is all being funded by additional specific funding, such as the NHS discharge scheme, the infection control grant, and particularly within public health realm, the Contained Outbreak Management Fund and the Test and Trace grant. The strategy for dealing with this additional spend has been to treat it as a one-off medium-term impact that does not affect the savings programme as much as we possibly can. Again, as at November, pre the spending review and the financial settlement, the provisional financial settlement, we faced unfunded costs of 210 million after government grants, of which 160 million could be met from reserves and other funding sources to plug that gap. Therefore, there was still a gap of £50 million that still existed, even though we put in £160 million of county council monies. So the local government finance settlement, so I'll give you a brief update now on what the local government finance settlement brought for us. Again, it's only a 1-year settlement, which is understandable, but it does hinder us very much so in respect of our ability to plan, particularly when we consider this against the backdrop of continued expected growth in adult social care and no doubt children's social care. These things need to be addressed, and a 1-year settlement doesn't help us to do that in any way. This provisional settlement was announced on the 17th of December and will be updated with a final settlement by the end of January, very early February. One of the key, I'll just go through the key changes or the key announcements within the settlement. The first one, which is probably the most important one from my perspective, is the change in the adult social care precept limit. As I said earlier on, it was 2%, we'd assumed 2%, and it had previously been an average of 2% in the preceding years. But the government have now announced that we can increase the council tax for 3% for the adult social care precept, therefore increasing the permitted council tax increase overall to 4.99% before a referendum will be required. We were also going to be receiving a sum of money in respect of social care, on the spending round, or spending review, the national figure was announced, which we based an estimate of about £5 million. However, within the settlement, it was announced that Hampshire County Council would only receive £1.2 million. This is because the way in which they've calculated the allocation. I won't bore you with the precise details, but in effect they weighted it far more to give more of the grant to those with a lower council tax base, thereby offsetting the fact that because we've got a high council tax base, we would get a disproportionately large increase as a result of the precept, should the county council take it. The remaining 3 items that I've got here are, we've got an additional £24 million for COVID pressures, general COVID pressures within 21-22, an additional £8.1 million to support the council tax on the basis that there'll be less people able to pay their council tax, and we have the new homes bonus allocation of £3.9 million, which is predominantly in line with what we had previously assumed. Now I'll just go through the reserves position. The reserves are used, as I've said, in preceding years, the reserves are used to help absorb the year in between which savings are made, as well as fund the capital programme, revenue, investment of transformation work, etc. and so forth. The total reserves as at 31st of March was 641 million, of which 351 is against those specific revenue programmes and capital spend. There's also, there remains £92.2 million within the departments, within the various departments' cost of change balances, and that's being used for the delivery of transformation to make further savings and to offset any further delays in savings that we achieve. We have £50 million within the to mitigate risks, primarily as a result of the insurance reserve as we self-insure, and we have the 15.4 within the school reserve and £22 million, which is within the general fund balance, which is broadly in line with the minimum reserves policy that we have to maintain. This leaves £111 million of the overall 641, which I've not yet explained. That £111 million is set out before you now in respect of the balance as at 31st of March 2020. I'll just briefly just give you a refresher of those various headings so you know exactly what they are. The Budget Bridging Reserve, that is specifically the pot that enables us to run the 2-year savings programmes, i.e. funding the in-between years and the late delivery. I should just note at this point that it is committed in full up until the gap year for SP23. So in effect, we have enough money to fund the gap year, to fund the investment and all gap years up to SP23. At that point, there does not remain any additional funds to therefore meet any further investment costs beyond that point or to offset delayed savings, which ties in with the view that SP23 savings need to be made within the year 23-24. The Invest to Save is the budget for IT works to deliver the IT transformation to help the departments to deliver their savings. The Organisational Change Reserve is a relatively small reserve, which is a residual sum that's based on the utilisation of corporate support for the additional amounts when departments make staff go through the EVR process. There is a corporate element, and this fund pays for that element of those EVRs. From all of the reserves, the uncommitted balance is what has been used to identify the £160 million I referred to earlier on in order to respond to COVID. So it's not just these reserves, there are other things that have been identified in order to find that £160 million, but it's the uncommitted element of these reserves that have been put in to fund the £160 million that's needed to support the gap for COVID. So very briefly, I'll start you off with and Graham will come in towards the end of this, the transformation to 2021 programme. Again, as highlighted previously, there are no new savings in this round, and the £80 million T21 savings programs were agreed in November 2019. Delivery on those progress throughout 2020-21 and into 21-22, and these will be recorded and reported accordingly to CMT and Cabinet alongside the costs and the activity that relates to response and recovery for COVID. Again, as highlighted, the approved adult social care or adult social care T21 plan does have significant delays for the delivery of savings. So the approved plan already built in significant delays for delivery of savings due to the complexity of the programme. The lead-in times for the activity to deliver those savings is quite extensive. But these delays, were met in part from the department's cost of change reserves, which has been boosted during 1920 and 2021 from early delivery of savings. However, those early delivery of savings aren't as great as we were previously hoping they would be as a direct response to the work being undertaken on COVID, distracting the department from delivering savings. Therefore, a further contingency has been held corporately in order to mitigate those loss of savings as well. Before I hand you over to Graham, I'll just briefly show you a reminder of the savings proposals for 2021. You'll recall there's £43.1 million of savings within Adults Health and Care Department, of which £6.8 million is specifically to be funded or found from public health. Graham, did you want to progress on this side?
Yeah, thanks, Dave. Members, clearly, as Dave is working through this, you'll appreciate, given the size and complexity of the budget, financial planning of this order is indeed a highly skilled, very technical enterprise. I just wanted to pick up on a few key points as we go forward, literally speaking to a couple of slides. From transformation to 2021, clearly what we'd set out some time ago in terms of the current year financial budget and indeed those transformation opportunities we'd identified, whilst they all hold still true, they've been very, very significantly disrupted through this year as a consequence of COVID. And we do have, as we sit here today, but also in the coming months and indeed beyond, we are going to have some real challenges. And we've picked up on it to some degree in earlier presentations. So particularly Councillor Carpenter and Councillor Carew's comments about supporting the sector, making sure that staff are adhering to the appropriate guidance, that we've got testing in place and so on and so forth. All of those issues go into some of the immediate challenges we've got around quality, capacity and the appropriateness of services across the County of Hampshire. Some of them are absolutely within greater control, so those directly delivered services by ourselves, but we're working with a very large and very disparate sector. More than 35,000 people work in the social care sector across the County of Hampshire. And of course, it's very complex and it's very complicated. As we look forward, because of the impacts of COVID, the challenge of making transformation to 2021 and indeed successor programmes, savings plan 2023 become more challenging just in terms of needing to do multiple things at the same time, which is based on keeping our population safe and appropriately supported, using opportunities for working differently with individuals, whilst at the same time being resilient to what's going on around us at any one moment in time. We have also got continued development of extra care and supported living. Part of our strategy over an extended period of time, certainly the last decade, and will continue to be as we go forward, is that investment into high quality different accommodation models, of which extra care both for younger adults and older adults is absolutely key. We are going to be continuing and needing to continue to promulgate and support a message about keeping as many of our population well and undertaking activities and leading lifestyle behaviours that keep them well as we go forward. We call that the strengths-based approach. So how can we support individuals in our communities and more generally our population to do the right thing by themselves in order to stay well, to live independently? And how can they ensure that not taking risk in terms of how they lead their life is something they may choose to do, and how can we support them to do that? Of course, closer working with our colleagues in the NHS. Some of the things that we've seen absolutely through our response collectively to COVID are new ways of working with the NHS, which have enabled us collectively, I think, to progress probably 3 or 4 sort of generational changes that we might have otherwise seen. We've got to capitalise on those as we go forward, but again, given the challenges we've got, that's not easy. It's fairly easy to say, but actually transacting it and making it happen and embedding it is a more difficult challenge altogether. And finally, what we're seeing are delays in delivery of our T21 as a consequence of our response to COVID. And depending on how long COVID is with us and the lockdown measures that we've got and the measures that we've had to put in place, of course, the impact of that delay will either be short term, medium term or slightly longer term. So we need to bear that in mind as we go forward. Thank you, Dave. I'll just cover a couple of issues if I can in terms of just broadening out in terms of some of those challenges. And again, members, I'm sure you'll not be surprised to hear from me as an old social worker and somebody that absolutely is focused on operational delivery of excellent services that keeps our population well, that we have got a continuing challenge as we go forward in terms of the increasing complexity of the needs that we need to support across our population. We also are aware that clearly there are consequences of COVID, the so-called long COVID, that will continue to be endured by many residents in years to come as we go forward. So we are seeing complexity continue to increase. It's nothing new, but added to that, we have also got some of those challenges that come from COVID itself. The care sector has also been very, very significantly impacted, both financially in terms of its workforce by COVID. Again, positively, we were able to give you an update earlier in terms of the kinds of support, not only financial, but wider workforce support that we've been able to provide to the sector. But again, members, it's something that you will all understand on many, many levels. The level of fatigue that is being felt by the wider social care sector in terms of working in response to COVID at pace for now the best part of a year, and we're not through it yet. Hopefully we will be, but there are consequences in terms of a beleaguered and fatigued workforce that again we continue to focus on very adroitly, along with the reduction in the numbers of people being supported in the residential nursing care sector. That's really as a consequence of what we saw in the spring and early summer of last year. I'll not rehearse that too much here, but just to say that the sector generally is in a different place to where it was. It remains resilient, but its ability to remain resilient over the coming months and years is something that, again, we keep a very close scrutiny and eye upon. Recruitment and retention, we've got other broader challenges going on around us at this moment in time in terms of a workforce, that is the UK recruitment sector, into ensuring that where we possibly departmental strategy, looking at the way in which social care continues to develop in many ways, and I say this without wanting to particularly blow our own trumpet, but members will be aware that Hampshire County Council has got a proven track record in terms of innovation and developing new ways of providing better outcomes using the available resources, predominantly through technology, but not only through technology. We will continue to do that as we go forward, and also making sure that we're doing multiple things at the same time. So not losing sight of where we want to be over the coming years as a consequence of being down in the ditches dealing with COVID at the moment. We're keeping an eye both for the future, but all absolutely on in terms of where we are now and what we need to do to support our workforce. Thank you, Dave.
Thank you, Graham. Simon, are you able to present the public health position?
Yes, very happy. Sorry, a bit of a slow mute button. Yeah, thank you, Dave. If you just move on to the next slide, I'll talk a little bit about some of the public health challenges that we are facing going forward. So, like Graham's outlined for adult services public health, there's similar saving programmes to support the council's saving programme, alongside the challenge that NHS services are open, and some of them are open access, so we need to kind of manage demand in a slightly different way and maintain that clinical safety. And that's particularly relevant for some of our services around sexual health, health visiting and drug and alcohol services. Furthermore, the national agenda does push prevention up the agenda, which is really, really positive. And we can see that, particularly with COVID, that actually prevention is key, and we need to kind of manage that. So we have a leadership role across the council and the system working with the NHS. And one of our statutory duties is to provide public health input to the NHS, which we do. And then furthermore, thinking about our capacity and expertise to deliver across all of the public health responsibilities, we have a public health strategy, which is being delivered well and will shortly go through to Cabinet. We need to deliver our mandated services, which are wide ranging, including, as I mentioned, health visiting services, sexual health services, health checks for heart disease, and a number of other programs. So we're kind of working through that. And as you can see, the third bullet there, responding to emerging public health issues, COVID being one of them, but there are others that we are dealing with on a very regular basis that are behind the scenes, but any public health emergencies, we take leadership there. And then we are protecting the health of the population, thinking about that spread of infections. And really, I think this is a part of the remit of the team that was probably less well seen, but actually we do that all year with all sorts of different diseases, and COVID just brought that to the fore. So we do need to further maintain our focus on the key priorities of the system to ensure that the whole system takes prevention seriously, that we see the NHS really playing its part across its role, but also district councils, voluntary sector and others to take prevention seriously and really use evidence-based prevention. And we're doing that well through a number of different boards that we lead. You may well recall, for those around, that we do have a leadership role with the Isle of Wight. So I'm also the Director of Public Health for the Isle of Wight, and we need to make sure that we have the right capacity to provide that leadership, that public health leadership for the Isle of Wight and all its public health needs. With all public health kind of challenges, and particularly you'll know that Public Health England is changing its role. We are waiting for our final funding model, which colleagues for last year came through, I think, on the second week of March. For April, it's very challenging when you're working at that time scale to work out how to plan your budgets, and with Dave's help we get there, but it's not an easy timing for us. And then I think, as we've all said, COVID-19 has really highlighted the need to focus on improving the health of the population, because we know that some populations have been hit harder by COVID, not only population groups, but those with certain factors such as obesity and smoking. So how do we work together on that? Thanks, Dave.
Thank you, Simon. So I will just forewarn you at this point now, I will just take you through a few slides with the various numbers on. I'll just try and add a bit of context to them as well. So first of all, this is the adult health and care budget. It's a couple of slides because there's an adult social care budget and a public health budget. So respecting the adult social care budget, you can see that we have a revised budget for 2021 of just over 414 million, and a proposed budget in 21-22 of just over 357 million. I should just highlight that that reflects the fact that all £43.1 million has come out of the budget, so that will account for a large part of the difference. In addition, obviously from 2021 to 21-22, there is inflation added to the budget, and there is also growth funding for adult social care in line with the published medium-term financial strategy. Both of those are actually an addition of £29 million. However, the single biggest reason for the difference is the fact that in the current year budget we have all of the cost of change activity to be undertaken during the year included within the budget, whereas in 21-22 at this point in time we do not have all of the cost of change activity built into the budget. That will come into the budget in April 2021, and we will see a significant increase in the overall budget from that point onwards. But in order so that we have a consistent approach across all departments, we have in effect a line which represents the ongoing funding that's available within each department. That's why we do it in this way. But it's not particularly alarming that there's a significant reduction when we take into account that we already know that £43.1 million was going to come out of the budget for transformation savings. I would just say members will be aware that at the best of times, predicting activity in adult social care and the corresponding spend is very difficult in such a volatile area. Obviously, that's even more difficult for next year as a result of the COVID pandemic and the exact impact that will have on client numbers and or the market, and therefore the price we pay for care. So whilst we've built a budget that's within the cash limit, it's right for me to emphasise that a risk still exists that activity could outstrip the budget that we have. However, the department is well placed to take remedial action to try and resolve that if it should occur. In respect of the capital programme, the revised programme, or sorry, the proposed programme for 21-22 is predominantly the Disabled Facilities Grant, which is in its entirety given to the district and boroughs, plus the normal allocation of around £481,000 for maintenance and upkeep of the department's estate. Plus, there is an additional £855,000 that's been transferred from 2021 to transfer into next year, so that it can be available for further works in respect of the older adults estate, and that £855,000 will go alongside a further £2.2 million is in a cabinet report just before Christmas to make an overall fund of about £3 million, in addition to what the department has previously had, to try and bring the estate up to the required health and safety and all urgent works that are required to be completed within the next year. In respect of public health budget.
Sorry, Dave, can I just come in at that point? Can you just go back to that slide?
Yes.
Members, sorry to cut Dave off as he's speaking. In the presentation in the ModGov version, you will see the revenue budget figure is different in that presentation. My apologies. The number in the ModGov presentation on slide 24 is the departmental budget, so both adult social care and public health. So my apologies for that omission on my part, that error. We will make sure that this revised slide deck, which is the correct numbers, as shown in the accompanying report, is made available to you. So as I say, my apologies for that error on my part.
Thank you very much, Graham. I think you're being far too generous there. But apologies, yes, it is something I meant to mention. So thank you, Graham, for raising that. So in respect of the public health budget, to be very clear, this is the public health service budget. That is all of the funding that's available to the public health department to manage. So it's not just the ring fence grant, and that can be seen in 2020-21 of a budget of £57 million, because that £57 million includes both the public health ring fence grant of 52,348,000 plus two one-off grants, most notably £4.79 million of the test and trace grant. So in 21-22, we have set the budget at 52,348,000, which is the same as this year's public health grant. It is still assumed to be ring-fenced, and whilst we have been informed that as part of the spending review that the grant would be maintained, we are uncertain as to what exactly maintained entails. So that could be maintained in real terms, or it could be maintained in cash terms. The two will be very different numbers. So at this point in time, we've just kept it at the figure that we've got for this year. If the grant changes, either increases or decreases, I would anticipate there will be an increase if it moves at all. That will be reflected and included within the public health budget by the 1st of April 2021. This slide is just to give a sense of scale of the department, and certainly a context of where the money is really spent. So what I would just say is that the purchased care budgets and the provided care budgets, i.e. all the purchased care for younger and older adults, and the HCC care budget, equate to 76% of the adult health and care revenue budget. But those same items equate to 87% of the adult social care budget. So of all of the money we spend on adult social care, 87% of it is direct provision being delivered to people either in a community setting or within a residential or nursing home. The final slide is in respect of the capital programme, which just breaks down what I was saying earlier on in respect of the Disabled Facilities Grant, the amount of money that's been transferred to next year for additional support for the estate, and our normal £481,000 we normally get given every year for the capital programme. So that concludes the presentation from myself. Graham, Simon, is there anything further you would like to add before?
Nothing from me, Dave.
No, nothing from me either. Thank you.
That concludes the presentation. Thank you very much.
Thank you, Dave. Thank you, Graham, and thank you, Simon, for taking us through this important but complex budget, no doubt about it. It's vitally important for the work that we do as a county council for our residents. Members, are there any questions?
Yes, Chairman.
Yes, Councillor Darden.
Yeah, thank you, Chairman. Dave, thank you for going through that. Very interesting. Can I ask you a few questions actually, but the first one is that you've made an assumption, I think, of 8.1 million, I think it was, quickly, I haven't got the figures in front of me now, where you were talking about for people who can't pay their council tax. Is that correct? What was that figure?
It was £8.1 million.
Yeah, okay, that's right. Now, how can you make that assumption when, because of COVID and business is presently in dire straits, a lot of them, of course, because of the COVID, how can you make such an assumption? Because it could be far greater or it could be less in these circumstances, because there's so much uncertainty. I can understand when you make a normal assumption because you've got other years to go on, but these are very difficult, unusual times. So I'd like to ask that question first.
Okay, Councillor Dowden. I think possibly I've probably not explained something fully. That £8.1 million is not an assumption from the County Council or the Finance Department within the County Council. That is an announced figure that's being given to Hampshire County Council by the government to support shortages in the delivery or the receipt of council tax income.
Okay, thank you. And the second question, obviously, we've I can clearly see, because of the financial situation we're in as the nation as a whole now, because there's not many money trees left now, and quite frankly, they've spent so much that the national debt is unbelievable. But clearly more money is to be spent. So are we likely to get any more money in February from government, as we're assuming there may be the possibility?
As I say, as the presentation shows on literally the line above there on the on that slide, that we will get £24 million, an additional £24 million in 21-22. Whether there will be any further funding is very much unknown at this point in time, and that is in respect of specific general funding for COVID, i.e. not against any specific action. Clearly, at this point in time, we do have access to the Contain, and it's led by Public Health, the Contain Outbreak Management Fund, which is based on £4 per head of population for every 28-day period that we're either in national lockdown or within Tier 4. So there is quite extensive funding coming towards Hampshire and every other local authority in respect of that specific stream. But at this point, and to be fair, there continues to be additional funding available for clinically extremely vulnerable people. What we're referring to, particularly within this slide deck, is that the general loss of council tax business rates, fees and charges that you would otherwise gain, and or general expenses or general costs associated with COVID, those we still have a gap. Using the figures from November, where we had a £210 million gap, of which we've met, sorry, that's 210 million after the government funding, of which we've met 160 million, there still remain £50 million gap. If I was just to take the £24 million that's been announced within the financial settlement, we've now got a £26 million gap. But I know full well the position is going to change when the cabinet, within the cabinet report that goes in February.
Okay, and a further question, if I may, Chairman, is in regards of you say we can manage with the reserves what we've got left and whatever up until 2023. So that'd be the 22-23, the following year's budget, presumably. If we don't get further large-scale funding, we can be innovative, and we have been with technology. Obviously, extra care homes and whatever. We've made a great deal of savings as a county council, and in social care, we've been excellent, I would say. But on the other hand, there's only so far you can go. Unless we get further money, particularly next year in a big way, then 2023, we are in totally dire straits. Would you agree with that? I
think the numbers as they're indicating here would say that we have in effect exhausted our resources in order to do what we would normally do, which is to have the two-year gap in savings. And yes, it would be very challenging from that point. However, what I would argue is that between now and 23-24, there's obviously an awful long way to go, and most notably, the budget report in February may give an update on that position. So yes, it is very challenging, and we go into SP23 with very much limited resources to offset any delay in savings and provide any more investment in delivering the transformational projects that would then go on and deliver those savings. That's a very challenging position, but what I could say is a day in the life of local government finance can change very, very quickly.
Yes, thank you.
Chairman, I wonder if I might just come in and say a few more words in respect of that question.
Yes, please, Alan.
Yeah, thank you. So I think the comment is well made. So our proven track record around things like extra care housing, use of innovation and technology, of course, is true. But if we're to further accelerate the availability of things like extra care housing, there is a timeline that it will take for things to come online, as it were. So typically, you're looking anywhere between 3 and 5 years from the idea through to delivery of a scheme that's open and able to accept people. So to some degree, Councillor Dowden, I think you're absolutely right in terms of some of that timeline challenge we've got to do more around things like extra care. There are two unknowns that I would want to make reference to at this point. The first one is the future funding of social care, and of course we've had the promise through multiple timelines in terms of green papers and white papers in terms of the long-term funding of social care. We still await that, so that is the great unknown, if I can describe it in that way. The other unknown that we've got, which is in an altogether more positive sense, what we've seen through this year is the way in which a key area of our business activity, which is supporting people to be discharged from acute hospital settings, has been funded by the NHS in response to a new operating requirement because of COVID. Now, what we know is that our local partners, the CCGs, the acute providers, and indeed the community providers, are keen for that that methodology of short-term discharge funding to come from the NHS. It removes many of the old, traditional, historic barriers to getting people to the right care setting in as speedy and optimum a time frame as possible, because to characterise it in a particular way, it doesn't require the NHS or local government to fall out about who's going to fund what. And that is also a significant benefit just in terms of our ability as a department to not only do the right thing, but to ensure that we remain financially fluid as well. So to some degree, some of the short-term benefit that we've seen through this year is the way in which monies are moving differently through the wider health and social care sector. Should that continue into the next financial year, that would be a significant continuing benefit to us in terms of the financial challenge, whilst at the same time maintaining excellent services that support the whole of our population. So those two unknowns are key. One of them has been with us for some time. The other is likely to only improve the situation that's presented to you through this revenue budget today. Thank you. I'll stop there.
Yeah, thank you, Graham, and thank you, Dave. I just hope that the government take note and value the work that local authorities have done during this crisis, and by valuing it, it needs to fund it properly.
Thank you, Councillor Darden. I don't see any more requests for a question. Are there any more?
Councillor Briggs, Chairman.
Sorry?
Councillor Briggs.
Councillor Briggs. Yes.
It's a question. It's a question for you, Graham, please. When you mention your strengths-based approach, is this to be continued after COVID? Because people seem to think when COVID's finished, our problems will be over, but they won't. There'll be more people with mental health problems. Some people have been shielding since March, and I've had calls from residents who say, I coped before, but I don't think I'm going to cope now. Is that all factored into the budget? Because I think it could be an immense problem. I know you mentioned long COVID, but I think I just don't know how you're going to cope with it all, to be truthful.
Yeah, thanks, thank you, Councillor Briggs. You're absolutely right. Those impacts and the legacy issues of COVID are going to be felt, in my view, for at least a couple of generations to come. Because not only will it be for those people that have been shielding, unable to access a whole range of services and support, we will also have through children and young people with particular support needs, an ongoing legacy issue into adult care that will live with us, as I say, for some considerable period. Our approach within the department, the strengths-based approach, is something that actually we've been doing for almost 5 years now. And it will absolutely continue long after this horrible COVID situation is behind us in terms of what we're experiencing in our communities. The consequence, though, in terms of how we can ensure that people are able to access a whole range of different forms of support through our strength-based approach, I think you're right, is going to be absolutely key and critical. I don't often speak about positives that we've seen over the last 12 months beyond the absolutely amazing dedication of colleagues across the entire public services and indeed the voluntary community sector. But one of the positive consequences, I think, is the way in which the voluntary community sector, the waft and weave of the places that we all live, has absolutely come to the fore in terms of the brilliant support it provides, the way in which it's able to, in a very sensible way, be able to provide a whole range of different forms of practical, emotional support to people across our communities. I think the consequence of that through COVID is that actually we've got a wider and deeper voluntary community sector in Hampshire that we continue to work with in terms of our strengths-based approach. So my view is it gets only stronger and better from this point forward. It's absolutely key to making sure that we're able to support each and every one of our residents that needs the kind of support that we're here to provide.
Thanks, Graham. That's very reassuring.
Roger, you're on mute.
Thank you. I've had a request from Councillor Carew to ask a question. Councillor Carew.
Chairman, can you hear me?
I can.
Jolly good. Thank you for bearing with me with all these IT problems I've had this morning. Right, my apologies, Dave, if I've misheard something, because your particular sound quality wasn't very good at one point. Could you explain to me, there is a significant difference between things like the revised capital programme and the proposed programme for 2021-22, and likewise with the revised budget and the proposed budget. Can you explain that disparity? Because I'm afraid I must have missed it.
No problem at all. I'll just go through that for you. So I think I've got the right slide on the screen. Is that the one you're referring to, Councillor Carew?
Yes. Right.
So I'll just start with the capital programme first. The capital programme, each year we have the 21-22 is just the new schemes that start in 21-22, and predominantly that's over £14 million of that 15 million is in relation to the disabled facilities grant.
Yes.
Which is a fund which comes into the county council and we distribute directly to
the districts. Yeah.
Districts and boroughs. Yeah. So the revised programme for 2021 is everything that we're currently doing this year. Now, inevitably, what will happen, and as you, within the actual capital report, you'll see that the revised programme for 2021 was increased by about £11 million at the start of July, in July 20, because of the underspend from the previous year. So what will happen is, in effect, the 25 million relates to the works that's planned for this year. The 15 relates to works that are planned for next year. But anything that doesn't get completed in this year from that 25 million pounds will roll forward into 21-22, and therefore by the time we get to July, what you'll probably see is a revised capital programme for 21-22 of circa 25 million pounds.
Perfect. That explains it perfectly. Thank you very much.
Okay. So in respect of revenue, there is a distinct disparity. Predominantly, that's because the £43.1 million transformation to 2021 savings have been removed from the budget.
Yes.
But it's not just that. What's also happened is there's kind of like a difference in basis between the revised budget and the proposed budget. The revised budget includes all of our ongoing funding, plus the cost of change, which is the one-off spend for the year that we're planning to utilise in the year, whereas the proposed budget doesn't include any of that cost of change activity. So come the 1st of April, we'll very quickly put in all of our cost of change spend plans, and that budget will increase by probably circa about another 10-15 million pounds possibly. I don't know the exact numbers off the top of my head, but the difference is because the savings are coming and because the revised budget includes cost of change funded activity, whereas the proposed budget doesn't include that amount just yet.
Understood. Thank you very much. That's very clear.
No problem. Thank you very much.
I don't see any more hands up for questions. So thank you again to the presenters and your answering of the questions. You will have noticed we've elided into item 12, and items 11 and 12 are now fused. Is that a correct interpretation, Dave?
Yes.
Yes. So we've got two sets of recommendations before us. So we'll keep them separate. So the item 11 recommendation is there before you. It is to support the recommendations being proposed to the executive member for adult social care and health, support the recommendation being proposed for executive member for public health. So that's the item 12 area, and agree any feedback or additional recommendations for consideration by the executive member for adult social care or the executive member for public health. So we'll just split those down again. You should now
Chairman, Chairman,
Yes.
I've just launched the electronic poll for the first recommendation, so hopefully members will see the box pop up in the middle of your screen. If you could please select agree, disagree or abstain. If you're an officer or observing, please don't vote so that the vote will be calculated correctly.
Thank you, Maria. That's exactly what I was because it did come up while I was speaking, but you've made it absolutely clear. So can I invite you now, members only, please, not the co-opted members, to vote on item 11, part 1, agree or abstain.
Chairman.
Yes, is that Councillor Harrison? Yes.
Yeah, we've had questions to officers, but we haven't had an opportunity to debate before we vote on the recommendation.
Okay,
I just wonder whether I might make a contribution.
Yes, Marie, can you take the vote page down so that we do have a debate if required? And we'll come back.
Okay.
While that's happening, yes, please, debate, Councillor Harrison.
Thank you, Chairman. For my part, there is relief that there are no further savings or cuts being proposed, at least on this occasion. I think there's probably a collective concern amongst all of us on whether we will have sufficient resources to meet what is increased demand, not just this present COVID situation, but as we know, the population of Hampshire is becoming older, frailer, and more in need of support. Also, that cuts to public health and adult social care savings may turn out to be a false economy. We all know that prevention is so much better than cure, and savings which appear to be savings are not when you consider the longer term aspect of this. Chairman, if the government had been better prepared for the expected pandemic, there would be much more resources available to protect our population. I think officers are doing a great job with the resources that they have, but all the same, I'm going to abstain on this occasion. I recognise that you have to set a budget, but I am not happy with government policy, and I'm not happy with the situation that we're finding ourselves in, and abstaining is probably the most appropriate thing I can do in the circumstance.
Thank you, Councillor Harrison. That's an honourable position. Are there any other contributions to the debate?
Chairman, I have a similar view as Councillor Harrison, but in the front, still on my screen, it says that agree 100%, disagree no percent, or whatever. We haven't had a vote yet.
No, Marie, can you explain that? Because I asked you to take it down.
I've closed it. The option I've got is to close it and then reopen it when you want to vote on it again.
Okay, we members, we're disregarding what is on the screen at the moment. We will be taking that vote again. Any more contributions to debate? No. Marie, can you therefore set up the vote again, please?
Okay, so I've reopened it, so hopefully everyone should see the pop-up again with the options to agree, disagree or abstain.
Thank you.
It's not working.
Right, on my screen it's showing that 85% of us agree. There is no disagreement. but 15% have abstained. So that is carried. Thank you.
So, sorry, Chairman.
Yes.
Say what you just said again. On my screen, it says agree 67%, disagree none, abstain 33%.
Yes, that's right. It's just changed again.
Oh, sorry.
You're absolutely right. It's changed again. Marie, is that the final tally?
That's 15 responses, and let me just check the number of members present. There are a couple more members than 15, but that does give us the majority.
So we've got two forms of abstention. We've got abstention digitally as displayed, and we've got people who haven't bothered pressing the button. Is that correct?
I believe so, given the number of members who are still showing as in the meeting.
Right. In any event, that is carried. Agreed? Record.
Yes, agreed.
That recommendation is carried. Right. Thank you. And the next one, which will relate to public health.
Yeah, I'll just launch that one. Hold on.
Is there any debate on the public health issue? No, I don't see any hands for that. So now we've got on our screen, should have item 11 part 2. This is support the recommendations for public health. Agree, disagree, or abstain. So please vote now. Is that the final? Is that the final tally, Marie?
Not working.
So there are 14 responses showing this time. Is anybody having trouble with using the voting? If anybody else would like to put their vote in the chat, if they can't use the poll, then that would be acceptable. I'm seeing 10 have chosen agree and 4 have abstained and 0 have disagreed. So again, this has carried.
Thank you, Marie. So that's done. Now the capital programme.
Debate.
Any debate on the capital programme? Don't see any hands for the capital programme. So can you put up the screen for the capital programme vote, please, Marie?
Yep, I've just launched that one. So again, you've got agree, disagree, or abstain, hopefully showing on your screen. If you have any problems with that, if you put your vote in the chat function instead by putting either agree, disagree, or abstain. Thank you.
So we can vote now.
I see 15 responses for this one. So I see 11 for agree, 0 for disagree, and 4 for abstain. So again, with the 11 agreeing, that is carried.
Right. Thank you, Marie. So that concludes items 11 and 12. The last item on our agenda is the work programme, and that's to consider and approve Health and Adult Social Care Committee work programme. Are there any contributions to that? Can we take that as read? And if people want to add anything, perhaps they would email me and Marie, and we'll see how we can fit it into the programme. The work programme is currently very full. Councillor Crew, you look as though you might have an addition.
Can you hear me?
Yes.
No, we can't.
It was really coming back to, we've obviously, as you're aware, we're looking at the future of Chase Hospital and a possible new health centre in Whitehall and Borden. But I was just particularly concerned regarding, recently we've had our Chase Day Centre closed, apparently due to lack of take-up, but we were supposed to be a dementia-friendly organisation with care home beds provided, NHS beds provided, and I just wondered whether that could be seen as part of either the new health care centre or whatever's happening to Chase. It just needs to be part of that conversation so it doesn't get lost.
Okay, would you like to email Marie
Yes,
with that, and we'll see where it fits best into the work programme. Thank you, Adam. Any other contributions? Can we agree the work programme?
Sorry,
general agreement. Okay,
sorry,
thank you.
Sarah, I've got I have my hand up as well, Chair. Sorry.
Oh, sorry. Please speak.
Yeah, it's just like you said, we have got a full work rota already, but I think it was Councillor Briggs touched on it earlier when she said about the concerns outside what's happening with COVID. I know personally 2 people. One of them, unfortunately, is now terminal cancer, and the other one, her cancer treatment has started, and she's going to be on chemo for the next 6 to 8 months. My concern is around patients that aren't being seen for their regular checks up or haven't been, and what the future holds for those patients. I know Councillor Briggs said around dementia and mental health, those kinds of issues which have gone through the roof, but it's the other issues that concern me as well, and what that will mean to us in the future, because those types of conditions are going to be very, very costly. And these are 2 people in Southampton. You know, there's another one in Leeds and Manchester, friends that I went to school with, that are in a similar position, that are waiting sort of for their prognosis, if you like. So it's just something that concerns me and something that maybe we should be looking at through our work programme, what's been left off and what it could mean to us in the future. Thank you.
Thank you, Tonya. Similarly, would you like to email something to that effect into us? I know in the media this morning they were talking about cancer treatments and the fact that because of COVID and the demands on hospital beds and so on, some cancer treatments have either not taken place or they've been deferred. The overriding factor, I believe, that the medics are taking is that where a cancer is life-threatening, it is being dealt with. Provision is being made to deal with it. Cancers, as you know, can be lightning or they can be slow. So we have to leave it to the medics to decide what should be done. But nonetheless, it would be good if we had all the resources we needed to treat all the cancer patients that we have. But that's not the case at the moment. But
I think that was part of the problem with 2 of those that I mentioned, Roger. That was part of my reason for bringing it up. Yes. One was due to have her 5-year all clear back in March, which was postponed due to the risks. Obviously, she was vulnerable, and now she's terminal. Whether that had been picked up in March, whether we'd be looking at something different now, I don't know. She doesn't know, and there's no way of telling, but it does concern me
that they're seen as not going into hospital because they're vulnerable, they're probably going to be all clear, and then it turns out they're not. So that's where my concern is.
Yes, an absolutely legitimate concern, Tonya. Thank you for that. Any other comments? So we've taken the work programme as is. We've got a couple of addendums that are going to be fed in by Councillor Craig, Councillor Carew. So I think we can declare the current HASC closed. Thank you all for your input and your forbearance. But I think it was appropriate that we spent all the time that we did spend on examining the current COVID situation. So thank you all again, and good afternoon.